Okay. Thank you for coming back so promptly after lunch. We will start now with the voting, and for that purpose, we have a practice question so that we can run you guys through the technology again of the voting machine. So let Celia actually walk you guys through this. Or Maggie.
I'll actually help you with a bit of the technology. So if you want to go ahead and press the top left on-off button to get started, if you want to hold that down. And if you've done that already, you can go ahead and enter the personal voting ID number. So there's a little Post-it note on the back of your name tense with a number on it. It's also on the clicker itself, so go ahead and enter that number. Do you want to do it? Do we have any? Okay. If you're having trouble getting it set up, Celia's going to be walking around and she can help you out with it.
How are we doing? Oh, not very. 14 people, okay.
Yep.
All right.
Including our ex officio, so 14 is the total.
All right.
We're good.
So we just need to see if they can vote.
So it looks like everybody was able to get into the voting session, and we're still waiting on 4 more responses. So if you want to take a crack at this first test voting question, which city or town in the greater Boston area is home to the nation's first Dunkin' Donuts? Great, it looks like we have everyone in. And so some varied responses. The correct answer on this was actually Quincy, but Quincy, Mass, which was C, actually. So, so now that we've gotten this out of our systems, we're ready to go, and I'll turn it back over to Steve.
All right. We'll see if we'll dodge that. Okay.
was V. Oh, pardon me. Okay. Sorry I doubted anyone.
It sounds loud.
All right, so we'll see how we do with the other questions coming up. Can you all hear me all right? Hearing okay? Okay, thanks. All right, so in the front here we have, again, the patients and the clinical experts and members from the ICER and obviously affiliated research team. So they are available to the CEPAC as we start to walk through the voting questions, which, even though we've had a very rich discussion and presentation already this morning, voting questions usually do raise different perspectives, different aspects of the questions that we need to talk further about. So let me proceed to the first question, and I'll remind the CEPAC that you guys have an evidence summary in your binder. You have your own notes on the full report, whatever else you've got, but these can often be helpful. So the first question is the evidence adequate to demonstrate that the net health benefit of apremilast is as good as that provided by any of the TNF-alpha inhibitors? Yes or no? Okay, go ahead. Okay, go ahead.
So, is this still working? Good, it's still working. All right, so let me look at the evidence table. So you guys, here I'm trying to figure out which of the tables is probably most germane to this question. Whether the results of the network meta-analysis is table 2, which I'm sure you've already noticed. You have, in table 3, you've got the PASI responses from the head-to-head trials with etanercept and ustekinumab. And that slightly reordered table in which you've got all of the head-to-heads is table 5, which is on page 4 of the evidence summary. And in fact, on that table 5, you'll notice, in anticipation of the voting questions, certain of the evidence ratings, at least in the report, have been highlighted in black, bolding. So you can see that top row with the apremilast. You see the ICER evidence ratings of I versus etanercept, C minus versus adalimumab, C minus versus infliximab.
The question that was raised during the public comment period about the comparison of apremilast to etanercept.
Sure. Can anybody hear me? Hello? Hello? Okay. The evidence rating for etanercept versus apremilast is I, and that we arrived at that rating for a couple of reasons. So Jeff mentioned the Liberate trial during his presentation. This was a trial that had an etanercept arm and an apremilast arm and a placebo arm. However, it was powered for the placebo comparisons, not for the direct comparison of apremilast and etanercept. And etanercept was used at a different dose level than what was approved, what is FDA approved. So we distanced ourselves from this trial in our review. In addition, there was a point made that the estimate of the likelihood of achieving PASI 75 was 1.55 for etanercept versus apremilast. However, we also were apprised that there was head-to-head clinical information comparing etanercept to its biosimilar, which is known by the brand name Erelzi. You'll also see that in your network meta-analysis table, and that was not a significant comparison. And in addition, the comparison of etanercept itself was really borderline because of there's a wide credible interval around that estimate. So for all these reasons, we felt that the evidence was insufficient to really make a determination between those two.
Good. Does CEPAC have any questions?
Yeah.
Yes, Chris. Oh, it's shutting off. Guys, can we have some...
Sorry about that. Anybody who already voted, we have to do some things necessary. So we just wanted to figure out the session on Zoom or if you want to vote, should be up to see.
Sorry for the technical difficulties, folks. I would actually ask the CEPAC, I know
for efficiency's sake, sometimes you want to jump in if you already feel like you know strongly what you're going to vote, you may want to introduce it. But it's actually helpful to make sure that you all get to hear each other's thoughts and questions and any other comments made before you vote. So try to hold off on voting until we kind of officially ask for your votes. All right. So any other questions about the evidence that would relate to this question about apremilast versus the TNF-alpha inhibitors? Jeff, is there anything that you feel needs to be reintroduced as part of the discussion? No. Okay. All right, then let's go ahead and take our first vote. Are we there yet? Oh, we're there yet. All right, so please go ahead and... All right, 14 no. The evidence is not adequate to say that apremilast is as good as, the net health benefit is as good as that of TNF-alpha inhibitors. Sometimes, especially if there's a divided vote, we ask for further comment just to kind of understand the thinking on certain questions. In a case like this, it's probably not too helpful to have further discussion. So let's go on to the next voting question. All right. Now, these are tricky questions that we don't always ask, but sometimes when there is a class, if you will, of drugs using the same mechanism of action, we ask if the evidence is adequate to distinguish the net health benefit among the drugs in a class. So that's the question that you're asked here. Among the IL-17 drugs, secukinumab, ixekizumab, and brodalumab, is the evidence adequate to distinguish the net health benefit among these drugs? So again, at least one source of information for thinking about this would be to look at Table 5 in the evidence summary.
Can I ask a question?
Sure.
Since it's a compound question because there's 3 drugs. Not that I necessarily think this way, but it occurred to me that what if I thought there was enough evidence between 2 of them, but not enough evidence between the other potential pairs?
Talk about that.
Okay.
So we should bring that up because we can either make it a very clear comment to the vote. We may have to distinguish it in some way, just so people will be able to interpret the vote adequately. If you feel there is one particular comparison among these that you feel does give you adequate evidence to distinguish the net health benefit, then we can certainly discuss that. For those of you who are looking at this table again, which is part of what you may want to look at, it's in the lower right-hand corner. You've got the 3 IL-17 drugs versus the 3 IL-17 drugs. So that relates to ICER's evidence rating. But again, that may be part of what you will want to look at. While you're looking at that, let me ask the clinical experts if they have any particular comment they'd like to introduce to this discussion on this point.
I'll just quickly add, and then I'll pass it off. I sort of agree with the question concern. I mean, I think at this stage, given some of the other unknowns about brodalumab in particular, I would have some reservations about whether or not some of the, for example, whether the side effect profile and/or the final efficacy data has been fully presented for us to make a decision based on that one item among the 3. I'm not sure if that's what you were implying, but that would be my take, and I'll pass it to Abby.
Yeah, I would agree with what Joe is saying, which is I think that really understanding brodalumab is really the unknown in this mix, and the fact that the trial was stopped at at week 16, and so we really don't have the opportunity for long-term data. I think is going to really hamper our understanding, at least in the short while.
Which you may guess is partly why we frame some questions as like this, which is the evidence adequate to distinguish? And the more uncertainty we have, the more difficult it is to distinguish what we know among these drugs. Other questions? Okay. I appreciate also, we're coming back to the value questions later, which have a lot more baked into them in terms of consideration. So this is on the net health benefit, the comparative clinical effectiveness. Why don't we go ahead and take our vote? All right. All right. So 11 folks voted no, the evidence is not adequate, and 3 voted that it was. Now, Austin, I'm sorry, I didn't go back to you to find out if you needed to have a specific coda to your vote, but would you like to comment on it now, and especially if you were one of the yeses?
No, I was not one of the yeses. I was just raising it because I was trying to see if anybody else had this thought in their mind. I wasn't conflicted, but it just occurred to me.
That's fine. Troublemaker, we like it. That's fine. So I would like to invite someone who did vote yes, again, to help explain and make a little bit transparent some of the ways that people are wrestling with these data. Would anyone who voted yes that the evidence was adequate to distinguish among them care to describe their thinking?
I voted yes, and I was wrong.
Roger, can you pull that a little closer to you?
I
Thanks.
was wrong. I had not attended to the chart that you just pointed out because I was getting ahead of people. I think I'll wait till you stop talking for the next question and improve my odds. Because looking at the chart, I agree that although you could argue about it, they're too similar and they're too indeterminate when compared with each other to be able to draw a conclusion.
So we do find this happens from time to time, so you would like to change your vote from a yes to a no?
Oh, if that's an option, yeah.
Yes, it is.
I think I misinterpreted, but I actually would want clarification on this so that I don't do this again. The C+, I had interpreted as the meta-analysis demonstrating moderate certainty of superiority, which I think is inaccurate. Okay, so I would like to change my vote as well.
Might not be a bad time just to restate what C+, both what it kind of means, at least in our vernacular, and then the evidence on which we based that judgment. Dan or Jeff?
Well, I was just going to say, let me try and reflect this off of Dan, because I struggle, having gone through this process the first time, this time. So C starts with comparable. C is for comparable, and the plus means comparable or better, or the minus is comparable or worse. And the B is marginally or incrementally better. So I just sort of think is that a fair summary? And A is superior. And then there's also a degree of certainty baked into it as well. So modify that, Dan.
So we have 4 categories, A, B, C, D, without any pluses. Those are situations where you feel you have high certainty about the magnitude of the net health benefit. When we get into plus situations, B plus indicates that there's moderate certainty that the intervention you're focused on has a small to substantial net health benefit. And if it's C plus, you've got moderate certainty that it's comparable, small, or substantial net health benefit. In both cases, you have high certainty that the comparison is at least comparable for C and at least incremental for B. That might have confused everybody even more. But so for C plus in this particular instance, moderate certainty that it's comparable or better, high certainty that it's at least comparable.
And all of these results, by the way, as you can tell from the color code, all the head-to-head results, sorry, I should say it differently. The comparisons are all indirect. So we have no head-to-head studies comparing these three.
Steve, so maybe Dan could just comment on how the panel should view the lack of direct comparative evidence.
So that's really something that you should be considering individually. So if you think about this particular comparison and your level of importance in wanting to see direct head-to-head evidence is high enough, then that's something that you should think about in your own rating of the evidence. In this particular case, so network meta-analysis is an accepted statistical approach to trying to combine both direct and indirect evidence. In this case, we, as Steve said, we only have indirect evidence. But accounting for differences between patient populations and the placebo response rates in each of these trials, you have an estimate for each comparison of whether there is a net health benefit on the PASI 75 to look at.
So you're saying then, in your opinion, we shouldn't be downgrading the strength of the evidence because of the lack of head-to-head comparisons?
Well, in our suggested ratings, we did. So if there was only indirect evidence, nothing ever got to high certainty. So.
Chris.
And just to clarify, Steve, here, this does not include quality-adjusted life years.
No, absolutely. This
Okay.
is the net health benefit. Some people would choose to use the model as a way to using QALYs, not the cost per QALY, but the QALY itself as a way to judge or to calibrate, if you will, net health benefit. Others people would rather not do that. So again, this is something that we leave to you. There are different methodologic and even kind of almost philosophic approaches to how we would use the results of a model to confirm or inform our decision around the net health benefit. So let's assume that we need to revisit the vote in a second, and we'll do that. But I just want to see, is that what you were going to ask for, too?
I was the last yes vote, and I now realize that I misunderstood the question. So,
Apologies. We do sometimes weave in almost what seem like double negatives. Is there not enough evidence to have adequate? So I will go slowly, and we'll try to make sure that you guys have the chance to digest the question. Any other questions about the evidence, though, before we retake the vote? All right, so why don't we, I'm sorry, Abby, yes.
I want to add that if indeed there is a black box warning regarding mental health, I think it's just an important perspective to have in mind that that would probably make a lot of dermatologists quite uncomfortable with that agent.
Right. I think we will clearly reflect in the way we write this up that, to our surprise, given what we were kind of anticipating, we will not be able to know the full judgment, certainly of the FDA, and in some ways we won't be able to have access to all of the data, perhaps, that they have that we don't have access to. But so that needs to be part of the rendering of this vote. Yes.
Stephen, to that point, net health benefits and net health harms are typically presented separately. Is that the context for this question? Are we thinking of just the benefits irrespective of the harms?
Now, to us, our net health benefit means what basically that is the net health benefit incorporates both the harms and the clinical gains. So this is definitely includes consideration of harms, side effects, etc. Okay, let's go ahead and re-vote on this question, please. Do we need to reset this to do so? Oh, it's already reset.
We were able to change our votes,
okay.
so...
Oh, okay, I'm sorry. So let's just go ahead and see what the re-vote looks like.
I still need to change my vote.
Okay. Well, we will assume then that it's 14 no. There we go. 2 no. There we go.
Yeah, that's a...
Wait.
This question is cursed.
Okay.
Show of hands, it's all no's, correct? Okay, done. We'll talk further about whether there would be a benefit to whom and in what way to have head-to-head trials as part of the policy discussion roundtable. Okay, let's go to the next question. All right. So since the vote on question 2 was no, meaning that there was not adequate evidence to distinguish among them, we are now going to ask you questions about the comparative effectiveness of the IL-17 drugs as a class versus other drugs. The first one is this: is the evidence adequate to demonstrate that the net health benefit of the IL-17 drugs as a class is better than that provided by adalimumab, one of the TNF-alpha inhibitors? So I'll go a little bit slower again, because now, in terms of trying to capture this,
Well, this is a different question than is on our sheet.
that's correct.
So.
The sheet just has the wrong intro to it. The sheet just has the wrong intro to it. It's actually the same question, it's just instead of yes, it says if the vote on question 2 is no.
No, but it says this had ustekinumab, if no.
Yes, you can forget that sheet, because if you turn...
I need a little bit more time, is what I'm saying.
So, sorry, if you turn the sheet over... So given that you have voted unanimously that the evidence is not adequate to distinguish the net health benefit of the IL-17 drugs, so now we're going to compare them as a class to specific TNF-alpha inhibitors. And again, Table 5 is probably going to be one of your considerations. I'll give you a chance again to kind of compare that. Are people able to kind of orient themselves with the evidence as they're finding it? So the way I would do it, just for what it's worth, if you look at that Table 5, again, if you want, this is just a place to start. If you take the adalimumab row and you compare it to the IL-17s, which you see is adalimumab versus secukinumab is an I, adalimumab versus brodalumab is a C-, and adalimumab versus ixekizumab is C-. Jeff or Dan, do you want to comment again about your knowledge of the comparative clinical effectiveness evidence? Jeff? Turn that on.
Those results are coming out of the results of the network meta-analysis, in which there were significant differences between adalimumab and brodalumab and adalimumab and ixekizumab, but not adalimumab and secukinumab. Right? So our confidence interval, or our credible interval, overlapped 1 for the secukinumab adalimumab comparison.
Right. And this is indirect evidence only.
And it's all indirect evidence. There are no head-to-head trials involving adalimumab or any of the IL-17A inhibitors.
Just a question, if I may.
Yes, please. Chris.
In Table 5, if you look in the lower left quadrant, comparing the IL-17s to adalimumab, there are 2 C pluses and 1 I.
Right.
But then when you take the row, adalimumab, over to the right, top right of that, then you have the insufficient evidence and 2 C minuses. Okay. What should I be looking at?
Either one. Those should be mirror images of each other. So you should get an I in the same spot, and you should get a C plus where you have a C minus in the converse. That's exactly right, because it's comparable or better in one direction and comparable or worse in the other direction for where we feel.
Got it. Okay, thank you.
Yeah. No, it's challenging. I've spent a long time looking at this, and I always have to reorient myself each time. So, yeah.
Would either of the clinical experts like to offer their view of the evidence and how it's perceived in this kind of head-to-head way?
I want to just reiterate again, from a clinically practical, just from a practical standpoint, that while we're talking about incremental negatives here in the methodology that we spoke about that's largely PASI-driven, largely. I would just like to again remind everyone that there are myriad nuances that would clinically have us choosing one over another, with a net health benefit that is really based on the patient-physician discussion. And I just want to emphasize that again, because this is going to be a very different story when other things that you can't artificially remove from this a given patient situation is going to come into play. So if I have someone with bad arthritis in front of me with uveitis, with something that one drug treats and another one doesn't, or a response in the past, and I understand I don't want to muck up the voting, but I just want to reinfuse that clinical reality into this, and I think that shouldn't be overlooked. And I think in many ways we like the idea that we should be able to have a full breadth of these agents available to us.
We will definitely, I mean, again, that's kind of the translation of the evidence, which is always going to be limited in terms of how it captures all of the different nuances and different types of patients. That will be job one of our policy roundtable, is to talk about how those two kind of fit
Understood.
together.
Yeah, I just want to make sure I infuse the
that's
physician voice again, just in
No,
case.
absolutely. It shouldn't be absent from their considerations, but we will obviously emphasize that on the policy roundtable too. Jeff, did anybody else have a comment here?
Joe, it sounds like we're going to talk about this more during the policy roundtable, about sort of just being more explicit about, so somebody with those clinical conditions, you might choose adalimumab over a IL-17.
Correct. There will be a number of clinical scenarios where that's the case.
Yeah.
And just to point folks to one or two good resources, there's one of our well thought of research groups, GRAPPA, has printed, for example, a table of relevant comorbidities and how all the evidence weighs among those comorbidities for which agent, just to give you a sense of the complex nature and such. So,
CEPAC, do you have any questions about your interpretation of the evidence? Okay, let's go ahead and vote on this one. Again, is the evidence adequate to distinguish, I apologize, to demonstrate that the net health benefit of the IL-17 drugs as a class is better than that provided by adalimumab? All right, let's see the results. 9 no and 5 yes. Okay? We probably owe it to ourselves to have just a brief debrief on what some of the reasons were here, since there was somewhat of a spread here. Steve.
I was a yes, and I interpreted adequate as being shaky, but I was perhaps convinced by looking at the PASI 90 and PASI 100 scores, which were not approached to the degree that the IL-17 drugs were with adalimumab. And so I think we did the network meta-analysis on some of those other markers. We may have seen maybe even a bigger difference with that class of drugs.
Okay, thanks. We'll be sure to note that as part of the description of the thinking that went into the votes. Anybody else who voted yes, have a different perspective on why they voted yes that they would want to add before? Okay, go ahead.
Just one additional thing to Steve is that I was struck by the much lower projected discontinuation rate for that class of drugs. Now, there isn't a whole lot of data, but it does suggest that there would be another marker of success.
Okay. Good. Okay. Anybody want to volunteer why they voted no? Ed.
I was just not as impressed with the data that was from the model rather than from the comparisons, direct comparisons.
Okay. Did other people who voted no find that to be an important part of their thinking? A lot of heads nodding yes. Okay. Anything else distinct from that you think is important to note around the voting? Okay, let's keep going. So the next one is going to be the IL-17s versus a different TNF and alpha inhibitor. The next one is versus etanercept. So here again, you guys are probably getting pretty good now at finding the rows and columns, so I don't think I'll have to walk you through that, but I'll give you some time. So this is, again, the 3 IL-17 drugs versus etanercept. And here we do have some head-to-head trials, obviously, to talk about. Clinical experts, I'll ask you folks, actually. In the clinical domain, your own gestalt, I know you're obviously your own clinical expert, but you talk to a lot of your colleagues. How much do they pay attention to the head-to-head trials as opposed to either very formal attempts at indirect comparison or more kind of informal attempts? How important is it to their view of the evidence?
Do you want to?
You know, I'd probably argue that that if you ask the key opinion leaders, they pay a lot of attention to the head-to-head trials. If you ask the practicing dermatologist, they probably take the table that you've outlined with the PASI scores and just make a mental comparison.
Fair?
Yeah, I think that's fair, and I think it's sprinkled with their own clinical experience beyond the data, probably more heavily than right. So it's always a combination, but I think, yeah.
Okay. Interesting. Questions from CEPAC about this particular comparison? And by the way, the reason that we have head-to-heads versus etanercept is because it's the oldest of the drugs and therefore served as a benchmark against which to test new drugs. Or is there any particular reason you think it was chosen as opposed to adalimumab?
As a comparator?
Mm-hmm.
Do you want to take that one? I might suggest that it is somewhat based on its PASI 75 effective. You know, it's the efficacy numbers that one sees and its perceived efficacy in the class. So I think it's not a surprise that might be chosen as a comparator in some cases.
I'll also add that when those studies were designed, etanercept really had very broad acceptance in the psoriasis community, so that it was the most commonly used of these biologics. So that I think there was justification for it in that regard as well.
Okay, thanks. Jeff, or again, CEPAC, anything else you'd want to add? Any other questions? Okay, why don't we vote on this one then? IL-17s versus etanercept. Is there adequate evidence to demonstrate IL-17s are better than etanercept? One more? There we go, thank you. And the results? 13 yes, 1 no. Okay, I think, little glance at the watch, I think I'll keep going unless, well, does the person who voted no want to, I guess we should check just to make sure, for instance, that it wasn't a mistaken vote. But to the person who voted no, would they like to comment? Roger? Can you, Roger, hit your mic?
I looked at table 5, and it had C minus, C minus, oh no, it had C minus D. Oh, he's pointing to something else. Yeah. Oh, well, okay.
Look at these three. But you got to look in tears.
Yeah. Okay, well, that's why I can't read this table. I'm just...
Well, we want to try to make, that's okay, that's what we try to make sure that people are happy with their final vote. Would you like to change your vote from no to yes? Okay. Sure. So noted. All right, why don't we keep going then? The last question, not surprisingly, is IL-17 drugs versus infliximab. Here again, there are no direct head-to-head trials, making sure I read this correctly. Dan, does it need to be stated again, or Jeff, why the results of the network meta-analysis were interpreted, at least by the ICER team, as suggesting that the evidence was inadequate?
Again, if you look at the network meta-analysis league table, so this one, because there are no head-to-head trials, and you start on the infliximab, start where infliximab is, we didn't find that we had a credible interval that overlapped 1 for comparisons with brodalumab, ixekizumab, and secukinumab. And so there's insufficient evidence to say that there's a difference between them. And there are no head-to-head studies.
So, Steve, so Jeff, could I just ask, what, that's certainly taking the PASI into account, but what about, could you comment on the adverse effects and discontinuation rates with infliximab and how that should weigh into an evaluation of net health benefit?
And I want to answer in the context of the way the question is framed. That I think that is right. We see that infliximab has higher adverse event rates than the IL-17A inhibitors, but we're uncertain about any differences in effectiveness. Dan, you want to augment that, or?
Right. And again, we're talking about trials where the harms that are reported, these trials are not powered to look at harms. So we're really looking at rankings of rates of harm across the drugs. And again, we have no direct evidence. So we're forced to look through indirect evidence at how these major clinical effects compare.
I'm curious if you use a clinical comment. So I will just say in registry data for infliximab, I think it's also true that we know some of the safety signals may be somewhat due to the population who are treated with the drug, who tend to have slightly more comorbidities or more comorbid conditions, which may drive some of the signal that we're discussing, and which so may make the negative side a bit unfair in terms of or biased. And I think on the flip side, as we've already mentioned earlier, I think that in true clinical practice that we are often using, again, as you've heard, doses that are higher and or at shorter intervals, which may vary the true effect in patients in its real clinical use, both in rheumatology, of course, and then in dermatology in this psoriasis space.
Abby.
I'm also going to add that in the dermatology space, unlike what I understand is in rheum and in GI, really dermatologists really didn't create infusion centers, so that that was not part of the dermatologic culture. So access is a huge issue with this medication for our patients. So getting treatments, and that's why the uptake, that's one of the reasons why the uptake of this medication in the dermatologic community has been so limited. And in addition to what Joe was saying about the fact that while every 8 weeks is the way it's the FDA has approved it, very commonly our patients are needing Q4-week administrations. And I think to your point earlier, that accounts for a lot of the loss of efficacy, accounts for a lot of the dropout.
Thanks. Actually, I was going to ask the patients too. Do you have any comment on how, when you hear the word net health benefit, and we're talking about discontinuation rates and some of these other features, how do patients hear this information and factor it into their decision making about net health benefit for them?
So I'll comment first and certainly then invite Chris to share some thoughts. I think as Mike Siegel summarized earlier, I think the individual patient is very focused on their own health journey. And so when they have the conversations that you've heard discussed today, I think it's less abstract for them. They're trying to take what they're hearing from their physician and understand how that's going to impact them. So I think they very quickly get to their own preferences and wants out of a therapy, and on the flip side, the concerns they have from a side effect standpoint or potential challenge standpoint with any one therapy.
Yeah, as a patient, I try to dumb things down in my mind before making a decision, and for me it's just convenience and well, like for biologics, I don't like needles, so anything without a needle, I guess. Unfortunately, they don't have those yet, so yeah, it's mostly just taking the big words and making them easier to comprehend. So
that'd be good for us too.
Yeah.
We could use that. Okay, thank you. Any other questions about the evidence related to this question? I think you probably are old hands at this now. Why don't we go ahead and vote, please? IL-17s versus infliximab. Almost there. Okay. All right, 13-1 again. Dr. Snow, are you number one again? No, you're not the same. Some other lucky person. Yes.
So I was
Steph.
the yes, and for me, the reason was thinking about net health benefit, and so thinking about comparable tolerability and also access, which I think is so huge, particularly thinking about patients in rural areas. So for me, thinking about total health benefit, that's why I thought a yes for this one.
Okay. Excellent, thank you. All right, we will keep going. We have a few more votes on comparative clinical effectiveness before we get to the value questions. So now, just to orient you, we're going to shift to questions about ustekinumab versus the 3 TNF-alpha inhibitors. And obviously, there is a policy kind of framework lurking behind these voting questions. And we'll get to a lot of it in the policy roundtable. But it's largely because the TNF-alpha inhibitors are considered by most insurers and many clinicians too, I'm sure, as the first step. And so there are questions about whether the newer agents, whether there's adequate evidence to kind of demonstrate that they are better. So for this one, we're going to ask whether ustekinumab, whether there's adequate evidence to demonstrate that it is better than adalimumab. So, of course, I tend to go to this table again, which is a summary, and you guys should think about the details as well. But again, you would want to take the row ustekinumab, and if you plot it out to adalimumab, you get an I. No head-to-head trials, a credible interval that crossed 1, I'm sure, in the network meta-analysis. Any questions from the CEPAC about the background of the evidence on this comparison? Okay. Any comment from patients or clinicians? Yes.
Sorry. As 30% of patients who fall into this category of severe psoriasis also have concurrent psoriatic arthritis, that's really a missing piece in this equation. And there is very much a distinction. While both drugs can be helpful in psoriatic arthritis, the TNF inhibitors are a stronger agent in this category.
While we're at it, I want to underscore what our patient, Mr. Pettit, said just a minute ago, which is, thinking a little bit about routes of administration in addition to all the mechanism of action and efficacy. He was not even aware that there was necessarily an oral alternative option we just talked about, for some patients, the fact that this is 4 injections a year is tremendous for them, and it can be administered in office as opposed to at home if they have needle phobia or something else. Again, just infusing some nuances.
Okay.
And I'll just go on to say on the flip side, when IBD becomes in the equation, then the drug preference might flip. So that there are definite, this is the constant comorbid disease that we need to be thinking about as we consider every one of these drugs in that unique patient.
Thank you. And I'll note also for the record that we will make sure in describing these votes that these really important issues of comorbidities and which drugs work for different components of these autoimmune diseases is not reflected in the votes here on psoriasis, but is a critically important feature of appropriate clinical practice and needs to be considered for coverage situations. Okay, why don't we go ahead and vote on this one then? Is the evidence adequate to demonstrate that ustekinumab is
better, the net health benefit is better than adalimumab. I think we're locked out again. One more voter. There we go. Okay. Is this the same one? No, a different one. Not Dr. Snow. He's quickly nodding. Okay. With the person who voted no? Okay. Chris, go ahead. Can you turn on your mic so folks can hear?
So after listening to Dr. Marola, needle phobia is a big deal. So if there is an alternative, I put that into the health benefit category.
We will come back to that as a potential other benefit in some cases. That's fine. Good. Okay. Here we go forward. Next one, big surprise, ustekinumab versus etanercept. There is a head-to-head trial here leading to a rating of B+ from the ICER team. If you want further review of the results of that head-to-head trial or discussion of the network meta-analysis, feel free to ask. Jeff, any comment from you specific to this comparison that you think is important? Trying to remember.
I think you've made the point that there's direct trial data here.
And I think the direct trial data is shown. I should remember that you guys can peek at that too, obviously.
CEP trial.
Table.
Yeah, table 3, the first trial there, accept.
Table 3.
That shows the PASI scores for etanercept versus 2 doses of ustekinumab.
Right. Right. Any questions? Okay, I'm seeing pretty confident faces so far. Why don't we go ahead and start voting? We have, thank you. There we go. All right, 14 yes, 0 no. All right. So we will spare the debrief on that one, and we'll go to the next question, which is ustekinumab versus infliximab. Here, unless I'm mistaken, there is no, right, there's no head-to-head data, so it's just the network meta-analysis, and the rating is a C- here. We probably ought to comment on that one. Go ahead.
From the network meta-analysis, so comparing infliximab, which appears in the network meta-analysis to be a bit superior to ustekinumab with a credible interval that excludes 1.
Abby, remember when you were saying how some practicing doctors just kind of do that relatively rough indirect comparison? If they did that for infliximab and ustekinumab, would they come up with the same general result we did, or would they think of it somehow differently?
I think most practicing dermatologists have so little comfort with infliximab because of the lack of access issues that probably would be a meaningless question to ask most of them. But I think that that if they were to look at these numbers, they probably would.
Interesting. Yeah, Jason.
I had a question for the clinical experts that is with respect to this question, but frankly, I think will be relevant to the subsequent questions. As a practical matter, do dermatologists assume that there's substantial heterogeneity of treatment effects? And the reason why I ask that is because if, in some of these questions, we actually do have high quality evidence. We have randomized controlled trial data that compare two medicines and show one's better. But at least, I know there's no data to assess my question, but anecdotally, do you feel that certain patients, for reasons of heterogeneity in populations, respond better to the medication that's been proven inferior in the RCT? Do you understand what I'm saying?
Yeah. So you're right that we don't unfortunately have yet. We wish in the personalized medicine world that we had a predictor of response. That said, there have been a couple of studies that have looked at some small polymorphisms that predict, as they do in some of our other, RA and some other diseases, that suggest that there may be folks who you can predict would respond to one mechanism potentially over the other, but nothing clinically available, nothing large enough. You can comment on that. I can tell you anecdotally, clinically, certainly we have patients who respond to, ironically, ready for this, sitting down, who respond to one TNF, and then not another, or the first TNF doesn't seem to work and the second one does, and that one's real hand-waving because mechanistically, we're sort of in the same camp at least. But between mechanism of action, for sure, anecdotally, clinically, there are responders, non-responders. Not very scientific answer, but.
There also are there are types of psoriasis that we really, that are more challenging. And as a rule, so for example, often palmar-plantar psoriasis, as an example, is a more challenging variety of psoriasis, all else being equal. And in those populations, sometimes we say the drug with the highest scores are the ones that are most likely to be most effective. But then we'll see patients who will take some of our weaker drugs and respond beautifully to it. And so that it's not an absolute. So there is a lot of heterogeneity amongst patients.
And I would just say your point about heterogeneity is well taken, but just want to make explicit it's in the full report. But our review specifically excluded people who had other subtypes of plaque psoriasis, so like erythrodermic, palmar-plantar, and other types of plaques. So that's sort of out of scope for this review.
Something else we should make sure to note around the votes. Okay. Why don't we go ahead and vote on ustekinumab versus infliximab? Okay, 13 no, 1 yes. The yes. Okay. Reverend Whitaker, use your microphone just so people can hear you.
Nope, I misunderstood there. So
okay.
that should be a no.
It should be a no. Okay. So 14 no. All right. We are making good progress. We are about to enter both what's easier and harder at the same time. We're going to start to talk about value.
Steve, one
Teresa.
thing, I just want to make sure that with the ustekinumab and etanercept, to also reiterate the comment of Gabby of the subset of people with arthritis, that I personally would go with etanercept, no question.
Okay, we won't put that in the report probably,
Well,
but we will.
no, but just a point that,
we'll
with the
raise the issue.
subgroup of,
We will,
with arthritis.
especially with psoriatic arthritis,
Yeah, I think that
we will raise that question.
And sorry, just to be clear, not just for patients with psoriatic arthritis, that would tend to tip you more towards the TNF alpha inhibitors. Just to be clear, yeah, we'll make, and that's not what we're discussing for purposes of these vote, but we will make it very clear in the final report that is a major consideration. We'll talk more about that.
Okay, so let's talk about value. Now, the preamble to these questions are long because we want you to obviously remember that value is a complex concept and there are different components to it. I was going to say the easy part is that most of the numbers that you're going to want to consider are all in Table 6 in your evidence summary, where you'll see the cost, the qualities, the life years, and the incremental cost effectiveness. But that does not capture the other aspects that we want you to think about. Okay, which include, as I'll read the question, given the available evidence on the comparative effectiveness and incremental cost effectiveness, using these estimated discounted prices, and taking into account other benefits, disadvantages, and contextual considerations, what is the long-term value for money of adalimumab compared to continued non-targeted therapy? So what you're going to get now are about 6 or 7 questions in which it's all going to be a drug versus non-targeted therapy, and then we'll have one head-to-head comparative value question. So that's why Table 6 has essentially all the numbers that you need for the next set of questions, because it's being asked about the drug versus non-targeted therapy. So I'm curious, as you start, again, to look at the numbers, which other benefits or disadvantages and contextual considerations are you thinking of as being important in your voting? And we can ask questions of patients, of clinical experts. Some have already come up, obviously, in some of the discussion so far, but this is where we want to make sure that we bring those up, and if it's going to be an important feature in your voting, we want to kind of talk about it. So any thoughts about this one? We use a general kind of range between 100 and 150,000, but that's...
Sorry, just looking for that chart.
Oh, actually, we don't have a specific chart. Oh, I'm sorry, is that what? It's tables... Oh, I know what you're talking about, that color-coded one? Yeah, that's right there. But obviously, there are always issues around uncertainty. They're around your judgment about whether the base case parameters were good, bad, or indifferent. And again, we want to raise the question of whether there are or aren't kind of really tangible, important other benefits or disadvantages and contextual considerations. Before we vote, I see someone pressing their button. Before we vote, can I ask someone to talk about their way of thinking about the value here? Whether they think the cost effectiveness captures everything that we need to talk about, whether there are certain features. Go ahead.
Well,
Austin.
just one thing that I'm reminding myself is that if I understood the review, evidence and value review correctly, that what was conveyed seemed to be that these may be slightly low, that maybe, there's things that might push the cost higher. And so when I'm looking at these, I'm kind of adding a little plus in my mind to them. Is that accurate?
Yeah, that is accurate. So I ran a bunch of scenarios to say, well, what if non-targeted doesn't offset, the costs are lower? What if non-targeted quality of life is actually higher? And I think you assessed it correctly. When I ran all those scenarios, generally these all stayed below 150 for the most part, but they did bump up more into the between 100 and 150. So I think your judgment's correct.
Sure.
So Steve, I'll just add on that, in terms of other benefits and disadvantages, I think we sort of have to come back. We've just gone through that comparison process where now we're back on targeted therapy, and what a game changer, not just the IL-17 drugs have been, but others, the other TNF-alpha inhibitors as well. So from other significant benefits, we have to come back to the immense psychosocial, employment, lifestyle impact of this. And but as a contextual consideration for me, the fact that there are the IL-17 agents which appear to be more effective at lower cost, or at least at comparable cost, in my mind downgrades this a bit, so I would vote for intermediate.
Interesting, okay. Now, when just so you know, these are the total 10-year costs in that first column. So the IL-17s are actually more expensive, but their cost effectiveness.
But the cost effectiveness ratio
right,
is
I just
better.
want to make sure that
Yeah.
that was right, what you meant. And one of the most challenging things in cost effectiveness is trying to figure out whether, the ways that the utilities were measured captured some of these kind of, mental health functioning at school, on the quality of life side. There's the economic side as well, but on the quality of life side, it's always difficult to say. Would you like to add anything to that perspective?
Yeah, it is hard to capture all the different aspects. I didn't mention there was one study where they tried to specifically develop an instrument in psoriasis, and they added in skin irritation and I think self-confidence. But they had trouble. It was hard. The measurement didn't really work the way they'd hoped. So it is challenging. You did mention the work thing. If you consider that factor that's kind of traditionally somewhat a little bit outside what payers consider, but not completely, I had mentioned, just to remind you, that bumped the ICERs back down maybe 10 or 20. So not to confuse you, but it's important that we do acknowledge there's uncertainty here.
One of the things that's reassuring, I guess, in some ways, and you pointed it out in your presentation, the utility, the quality of life of patients with psoriasis and the modeling is, I think, what some people would feel, clinicians would be even surprised to find so low, because you mentioned that it's the equivalent of having severe congestive heart failure. I'm not sure, I can't remember where depression and those kinds of conditions, but it's 0.642. I think that's, for those of us who look at these utilities, that's capturing a fairly severe impact on someone's quality of life. Whether it's completely inclusive or not, it's definitely down there. All right, Jason, yeah.
Can you just remind, I know this was addressed in the presentation, but those utility weights are derived from empirical evidence from randomized controlled trials? They're not derived from non-RCT based data? Is that right?
That's exactly right, except the weight, like the description of the health states comes from the trial, but then the weights that are put on, well, how is that quality of life compared to life and death? That comes from population-based estimates. So it's all a little confusing. I think the way Steve framed it best is that 0.64 is pretty low. So I certainly believe in our base case analysis that we have captured the impact on patients. I do not think we've underestimated it, would be my guess.
Okay. We've got 6 or 7 of these questions to go through. So, Greg, go ahead.
Thanks, Steve. Just one question. I keep struggling with this because there have been a number of comments around the heterogeneity of responsiveness with different drugs. And I would assume that there may be more heterogeneity in response to some of these agents than others. And if you don't respond at all, then cost per quality is going to be $2 million, or it's going to be a high figure. How are we supposed to be factoring that in? And if so, how do we do that?
That's actually a great question. In a way, it's in there, because imagine someone who gets put on TNF alpha, and they don't even respond during the trial. We account for that by assuming that about half of them go on to get a second-line targeted agent. And so, we're not looking at responders versus non-responders. We're looking at the population as a whole. But that effect of non-response and the fact you kind of wasted that money on that drug, for instance, is accounted for in the analysis. So I hope that helps a little bit.
Okay. Let's go ahead and take our vote. So, just to make sure it's all framed up again, this is the long-term value for money of adalimumab compared to continued non-targeted therapy. Please go ahead and vote. One more. Great. Okay, 11 intermediate and 3 high. For the sake of time, because I am sensitive, we want to make sure we have plenty of time for our roundtable that will deal with a lot of the important policy issues. If there's a strong majority, I'm probably going to try to skip through these, and we'll see if there's striking differences in some ways that might merit some further discussion. So we may have time to come back to this, but let's try going on to the next question, which is, surprisingly, we're going to go through them, etanercept versus non-targeted therapy. We're just going to run the row. Anybody want to ask any different questions about etanercept? Not sure there are likely to be specific other benefits different from what we've talked about with adalimumab, but open to comments? Okay, why don't we go ahead and vote on this one? Great. And, okay, so we have, shoot, now I can't remember. I know we had 3 high and the rest were intermediate. Here we have 1 low. And just to, again, I guess here we should probably ask a quick debrief. The low value voter on this one? Okay, so you thought the incremental cost effectiveness on this one put it into the low value? Thanks. Okay, otherwise the voting was relatively consistent. So let's keep going to the next question, which is infliximab. Dave, can I ask you to comment while people are just thinking briefly about this? Every time I've discussed this, this topic with payers and infliximab comes up, they ask a lot of questions about where infliximab is being given, because to them the cost can be very, very different depending on which site of care is used. Can you comment on how that was reflected in our report?
We didn't explicitly factor that in where it was administered, so that could have an impact, as Steve said, on the cost.
But didn't the base case assume it was given not in a hospital setting, obviously, but in a patient, in a
right,
doctor's
in terms of the administration cost, sorry.
The administration cost was, right.
Correct.
Okay.
Yeah.
So in the real world, apparently there are plenty of patients who are treated in a variety of different settings. So at least, if anything, the incremental cost effectiveness is likely to be tilted towards the lower side, given that we selected the lowest side of care.
Can I just add from a,
Sure.
from a patient standpoint, there are different cost sharings for infliximab versus the other therapies we're discussing. So I think it's something certainly we hear at the foundation a lot of challenges when you're looking at a Part B versus Part D drug situation.
So in general, for patients, it's a higher copay if it's a Part B. No? Yeah, it should be.
Well, it depends where your insurance is coming from. Right.
Okay. All right, why don't we go ahead and vote? I think that was helpful. And I want to encourage you to jump in if I'm going quickly, but you guys think there's an important other benefit or specific contextual issue that we need to slow down to hear about. One more vote, if everybody's, there we go, thank you. Okay, still the 3, the 9, and the 2. I'm just looking. Did anything about infliximab, because the cost effectiveness ratio is lower than etanercept, we have one more low value vote. Did somebody jump? Yeah, Claudia?
For me, Chris's comments just about not liking needles and weighed heavily on the contextual factors of having intravenously administered drug, the time commitment that takes, still relatively frequent in terms of dosing, so that really pushed me over into the low category.
Okay. Thank you. All right, let's go to the next vote. So now we're moving on away from the TNF-alpha inhibitors. We're moving to ustekinumab. So you can find it, obviously, in that same table. Same question, looking broadly at its comparative effectiveness, incremental cost effectiveness, other benefits and disadvantages and contextual considerations. What's the long-term value for money of ustekinumab? Dave, this had the highest incremental cost effectiveness. Any particular comment on that finding?
Yeah, it's worth discussing. The reason is because a third of the patients are getting double the dose because they're heavier, over 100 kilograms. And so this is, this is a tricky issue. If you looked at just patients that were getting the lower dose, that cost effectiveness ratio is going to be very similar to the others. And so this is a tricky one. And
but you did use the study's percentage of patients who would have needed weight-based dosing.
I would say that in the real world, this is what you're going to see on an average. On average, this is what you're going to see.
So I'll just add that psoriasis patients as a group tend to be quite overweight. So that is very much in contrast to other users of these kinds of medications. So, for example, rheumatologic patients tend to be, normal weight to thinner. So that is something that we grapple with, and so therefore that dose escalation is very important because it allows for much better efficacy in those overweight patients.
And a question for you, Dave. Remind me again, the 1/3, is that the U.S. population or is that trial data? Thank you. So that is real world represented in the base case. Thank you.
Joe.
I'll just add as well, similar to the infliximab conversation earlier, there are not as frequent, but certainly with some frequency, this drug also is used off-label at a slightly shorter frequency interval of up to Q8 weeks. We certainly do that with some of our patients, which would drive cost up a bit. And I'll just end with a commentary that there are a few other drugs in this space where two different doses are actually priced the same. And it's worth mentioning that this company has chosen not to do so. But there are other companies where twice the dose does not equal an increased cost.
Yeah, I think you kind of hit the nail on the head with the challenge that payers are facing around the value.
Good. Any questions from CEPAC or, again, other considerations around other benefits, et cetera? Abby, go ahead.
Let me just add, it was said earlier, but this is the drug that is administered once a quarter, and for a lot of patients, that is really a freedom from that kind of chronic drain of taking something so regularly, and in patients who are, who have less comfort with needles, that becomes a very attractive feature. People who travel, people, teenagers who are going to college, all those kinds of things, it really becomes very, very useful.
Thank you. Having a kid in college, I can certainly understand how that would be the case. All right, I think we're probably ready for the vote from the CEPAC perspective, so go ahead, please. All right, we're starting to get a certain pattern here. I'm sensing it. You guys, consistency is usually a good thing in some ways. So let's keep going. We're moving on to the IL-17As, starting with secukinumab. I'm not sure there is anything distinct, either Dave or Jeff, that you'd want to raise about the inputs into the model that led to that incremental cost effectiveness.
No, I mean, I can just reiterate, you have higher efficacy, we have lower discontinuation rate. Actually, with secukinumab, we do, as of a month ago now, have long-term data on that. You also have higher drug costs, so they all kind of balance each other out, and you end up with, again, don't lose sight of the QALYs. The QALYs are higher for this class of drug, but the ratio stays roughly the same as for the other drugs because all of those added benefits kind of are offset by the extra drug cost.
Chris.
And if I understand right, this is one that's every 4 weeks, so it's a little less frequent. Is that correct, typically?
I can reiterate the dosing intervals of secukinumab quickly, and I can compare it with ixekizumab. So just for everyone, so secukinumab is it's at the 300 milligram dose, which many of us use. There are two different doses, obviously, both. It would be 2 injections every week for 4 weeks, and then, or 5 weeks, however you look at it, and then monthly for the secukinumab. Ixekizumab is not that dissimilar. It's 2 injections up front, and it's essentially every other week dosing up to 3 months, and then it's monthly. So in the long term, you can think of them as both being monthly.
Okay, questions from CEPAC? Greg.
Is it appropriate to assume that the manufacturers are increasing the price because they've done these calculations and they know they have somewhat better efficacy and they can charge more?
That's the simple answer is it's impossible to answer. We don't know what goes into the pricing decisions for each one of these. I can say there's a lot going on in this space. You have a lot of competition, and you also have biosimilars looming. So there's a lot going on, and that I think plays into the pricing decisions.
Greg always wants dessert, I tell you. Chris.
Thanks. Just to confirm, this is as compared to non-targeted therapy.
Correct.
Right. So we're looking at an $89,843.
The base case ICER is 89,000 and change, yes, or 90,000. All right, let's go ahead and vote, as many of you already have. We're into the home stretch. There we go. All right. Now that's interesting. Okay. So we had a fair shift from the intermediate zone to the high value zone. Would a vote changer care to describe their reasoning so we can capture that? Someone who voted intermediate on all the others who voted high value on this one? There must have been at least 7 or 8 of you.
Yeah, I gave this one a high. Actually, I was getting ready to give it something else, but I was persuaded by the expert panel that this drug is more convenient to live with. So it's a sort of patient convenience issue that moved me to high.
Anybody have something?
For me, it's just
Rob?
about the superior efficacy of this class of agents.
All right. Okay. Good. Well, we get a couple more of them for you to vote on. Let's go to the next one, which is ixekizumab. Again, you can see the row. See the QALYs, see the cost-effectiveness ratio. And you've just heard about the dosing. Do you guys have any questions? Patients or clinical experts, anything we're missing that we haven't already talked about with one of the other IL-17 drugs yet? Okay. Then why don't we go ahead and vote, please? Take your time if you're still looking at the numbers, or if you need more time, but I think a lot of people are ready. All right. 8 and 6. All right. Am I imagining by chance that people are seeing an 89,000 cost-effectiveness ratio and a 100,000 cost-effectiveness ratio and treating that as a bright line and that's what's changing their vote, or are there other things just kind of curious, because there's been a couple people who've shifted back from high value to intermediate value, so I'm kind of curious why. Dave, did you vote? Well, let me find out from them first. Would somebody be willing who voted high value on secukinumab who switched back to intermediate here to offer up why? Yes, Greg.
Well, I did draw that bright line. I think this is a very expensive drug, and so I drew the bright line at 100.
Okay. Jason?
Yeah, similar kind of argument. I don't see these drugs are all better than non-targeted therapy, that's clear. But amongst themselves, I'm finding it difficult to see substantial differences in terms of their overall efficacy. And will be better in certain settings than others, and I appreciate that. But I moved back to intermediate because of the cost.
Okay. Jason, go ahead.
I was being a little reluctant because I wasn't directly answering your question, but just wanted to say that I voted high on both, which is why I wasn't answering your question directly. And I just wanted to, I agonized for a bit because, as everyone can tell, the incremental cost effectiveness ratio is near the normal threshold between high and intermediate. But what persuaded me, so obviously there's stochastic uncertainty, there's a variety of things in the models that you're very close to the line. But I have to make a decision. There's no option A and a half here, so I have to make a decision. And so the way I made the decision is again relating to this issue of heterogeneity of treatment effect, is that the quality increment with this particular medication is the highest in the list. And just to be clear about this, I'm not making reference to heterogeneity of treatment effect with respect to psoriatic arthritis. I'm saying simply for people with the disease condition that we are considering, there are going to be more challenging and less challenging cases. And I think this particular drug, because the quality increment is so high, may provide an option for those who would be otherwise refractory to treatment. And I was forced into this because we were so close to the line.
Okay. That's helpful. All right, we have one value vote left. I know you're disappointed. Oh no, we have two left, but we actually only have one left because I'm going to take executive or privilege here and say that we're not going to vote on this one. We could have decided not to vote on the net health benefit because, well, anyway, for this case, since we don't have a price, we had to take an estimated price. I think trying to grapple with the cost effectiveness ratio, it's there, and we'll obviously at some point know when we do have a price what to do with it. But for now, let's table this question and move to the last voting question. Oh, I'm sorry, we do have two more. I forgot. We have a vote on apremilast versus non-targeted therapy, and then we will have one head-to-head. Okay, Dave, you can restate the obvious about the fact, as you mentioned, lower qualities, lower price, similar cost-effectiveness ratio. Did I? Oral drug, maybe it's a good opportunity to have a patient comment. From what you hear from patients in either your own personal experience or other opportunities, how substantial other benefit is this to patients?
Yeah, so it is substantial to patients, and I think you see that in the discussion that took place at the FDA's patient-focused drug development meeting, and actually I'll direct ICER staff to the report, the Voice of the Patient report, which came out last night on that discussion back on March 17th. But this was a statement that came up many times there, the route of administration, patient fears about needles, certainly, and the option of an oral therapy is something that patients were very interested in. So it's absolutely, I think, a significant issue for them and something that a certain subset of patients is very interested in.
I'll just add that as well. So I can tell you, I think we all have the data in front of us. I'll add, we have a subset of patients taking it right back to the clinic. I have a good number of sort of particularly young women around college age who come to me, and all of the issues that come up around everything from birth control to alcohol to monitoring to being away from home to being all of the, to never having injected anything before, to you name it. Again, evidence pushed to the side for a moment, you can imagine that population is thrilled to have, as am I, to have an option like that where I'm not worried about pregnancy or alcohol use or need for blood monitoring for a whole variety of reasons. So I think it just comes back to our our nuances of treatment around certain populations.
And building upon that, I would also add that, we have to remember that 50% of the eligible patients for this, for all of these drugs are not being treated today. And what has been very remarkable, I would say, in the last year or two since the approval of apremilast has been the outpouring of patients coming into the office who often had not sought care for quite long periods of time, who were very excited about the idea of being able to take an oral agent, and for them it felt like a much more user-friendly option. So I think that the patients have spoken.
Interesting. Yes, we've got questions over here. Why don't I start down? Yes.
I have two questions. The first question is regarding adherence with this medication. Has that been a barrier that you've noticed in your patient population?
I think I've not found it in somebody who's a responder. I've not found that to be a problem. I think we lose patients on this drug because of side effects. So people who develop persistent GI distress, those patients drop off, and also people who don't achieve response. So those patients drop off. So that, in my mind, it's often an entry drug, but not necessarily the long-term drug.
Thank you. And my second question is actually about payment. Were coupons and rebates accounted for in this QALY as well as the injectable QALYs?
Were rebates included in the costs?
Yeah, coupons, rebates.
They were not included. Yeah.
Greg, did you have a question? I forget. Sorry?
So the net pricing data that was used for the analysis does take account of discounts and rebates. There may be couponing programs that are not part of companies' disclosed net sales, and those would not be, but discounts and rebates certainly.
Yes, sir. I was thinking at the patient level, those were not included. Yeah.
Okay. I think we should go ahead and vote then. It sounds like we've had a good discussion. Please go ahead and vote on the value for long-term value for money of apremilast versus non-targeted therapy. All right. Where's the vice president to break the tie when you need one? All right, some brief follow-up on this then. People were obviously, at least as a group, torn a little bit between high and intermediate value. So I'll start with the intermediate value. Cost effectiveness of $89,000. We heard it was an oral, which offers benefits to some patients. Intermediate value because? Greg.
It's not a particularly effective drug, and a fair number of patients are just not going to respond very well. And I also wonder, and the experts can comment on this, whether this kind of drug would attract patients with less severe disease, and whether that should be factored in as well.
Let me just actually, that's a great question. I did want to bring that up on the policy roundtable, because I think that kind of choice selection issue is what I want to focus on there. Anybody else want to offer up why they voted intermediate value on this one? Was it similar? I'm seeing shaking heads. Go
Sure.
ahead. Go ahead.
Had the same cost per unit improvement of outcome as other medications I rated in the same category.
Understood. Okay. So, and for the high, anything other that you wanted to add for high value? Yes.
I'll speak for high, the convenience of oral dosing and the price, and the idea that there's probably a subset of patients that will do fine with this and will never graduate to anything more effective.
Okay, Roger?
The same argument again, basically, the convenience and acceptability to patients.
Okay. So noted. All right. Now, if I haven't cursed myself, we have one last voting question on value. We decided to ask, again, about them as a class because their cost effectiveness is relatively similar. This is shown in Table 7, where you see, and focus for now on ixekizumab and secukinumab, just because the brodalumab figure, again, is kind of a construct. But we're asking what the value, long-term value for money is of an IL-17 drug versus etanercept.
Can I ask a question?
Yes, you may.
Apart from just kind of eyeballing and making a guess, is there any data-driven way to average these numbers?
Not unless we told you to consider them half and half or something. And we really.
I can do that, but I mean.
Do that.
You could weight it by.
I mean, you're right. We could have said right now in the market the biggest user is one or the other, so consider that one. We chose not to get into that too much. The one thing I thought you were going to ask is if you wanted to go back again to the relative certainty of these numbers. They've both been compared versus etanercept head-to-head, I would think. And they both received B+ rankings, would be my guess. I could go back to that myself, couldn't I? But versus etanercept, they're both B+. No, I'm sorry, ixekizumab is an A. So there was, at least in the ICER team's judgment, a slight increase in the certainty. Go ahead.
Compare the difference in the fixture trial with the Uncover 2 and 3 trials. The magnitude of benefit was that much more for the etanercept ixekizumab comparison versus the etanercept secukinumab comparison.
I'll throw in that the results from Uncover 2 and 3 were very consistent between them, so that's why we had higher certainty there.
Okay. So, but I will still say that we actually are kind of asking you to blend it in a somewhat awkward way, but that's probably with our general thinking that they're in the same close enough ballpark for policy making from your perspective that we could ask about them together. Any other questions about what we're asking you to do in this comparison? Okay, please go ahead and vote. All right, 13 high value, 1 intermediate value. Folks, I think that was a very well done discussion in which you really went after a lot of the important issues, both around the numbers and around some of the other issues, other benefits, contextual considerations. So I'd like to thank you for the votes, and our program director had guessed that we would be done with the voting around 2:30, and I swore I could do it by 2 o'clock. She gets a raise this year, and I don't. So we are going to just shift right into the policy roundtable, given that we want to spend an hour doing it before we make sure we get people out of here by 3:45, 4 o'clock. So the ICER research team can vacate spaces, and we have hopefully our additional policy roundtable members. Is Tom Kowalski here? I am. Fantastic, thank you. And Paul Jeffrey. Please come on up. Need my notes. Great, well, while we're all kind of getting sorted for this next round, can I invite the two new folks to introduce yourselves? And In so doing, just state if you have any relationships with industry, either payers or manufacturers, that should be noted before the conversation starts. Paul?
Not.
Yeah, turn those things on.
I'm Paul Jeffrey. I'm the Director of Pharmacy for the Massachusetts Medicaid Program, and I have no disclosures.
And I'm Tom Kowalski. I'm the Clinical Pharmacy Director for Blue Cross Blue Shield in Massachusetts, and I also have no disclosures.
So now we have this balkanized policy roundtable where we've got the payers all on the southeast quadrant, we've got the clinical experts up there, and the patients, as they should be, in the center of the discussion. So let me ask the patients to start off with here. Have we talked enough about how psoriasis affects everyday life and work? Was it captured to the way that you see things, in the way that this has been considered? And how, from a policy perspective, can the system do a better job of understanding the impact of a condition like this on patients?
So I would just begin by saying, I think from an NPF standpoint, we appreciate that the final draft of the evidence report noted a number of the issues that we raised in our comments, and certainly I think our conversations over the last 6 months have been informative for you and your staff in understanding really the challenging nature of living with psoriatic disease. You know, I think there's a couple of different ways of looking at this. One is that what the individual patient experiences is all that they know, and so it's hard to kind of judge what your experience as a patient with psoriasis is versus someone else's. I think, you know, at the same time, I would say what we see across the patient community is many of the same challenges expressed over and over by our population, and certainly the degree of the severity, as you noted in the report, is incredibly strong, and the impact that the disease has, if you're someone living with moderate to severe psoriasis, really permeates your entire life. And so the discussion in the report and that we've had here today about the emotional impact, social impact, work impact, all extending beyond the daily health management components of the disease, I think are really critical in thinking about the way this disease impacts a person living with it. I would also add that what we know from our survey data is that the impact of psoriasis extends beyond the individual patient to other members of the family. And so we have quite a bit of data that looks at things like the mental health impact of psoriasis, and we know that the levels of anger and depression, anxiety permeate to other members of the family that live with that person with disease. So,
yeah, it's what she said about patient doctor visits or experiences. Yeah, it's definitely different for everybody, and it's been a journey for me. I've had a few doctors tell me a lot of different things, trying a lot of different medicines and stuff. I actually just recently started biologics, so I've only been doing that for about 7 months. So it was years of a lot of topicals and just stuff to kind of hide it. So, and I was diagnosed, in the mid to late 90s, before biologics were even really a thing yet. So yeah, that for me personally has definitely been a journey as far as doctors go, and as the family life is definitely, it's definitely affected by it. Every day I worry about whether or not my kids are going to have it, so it definitely goes beyond me and the way my skin looks and how I'm doing on the inside, but it also, I worry about my kids all the time. So yeah, it's definitely it's a struggle. It's definitely it's been an up and down battle for a very long time, about 18 years now. So,
well, thanks again for coming out here all the way to talk to us about it. Sure, and then I have some
focus questions for you guys too at the end. Go
I
ahead.
want to just add something that I often hear patients tell me. I'm struck as a physician that I've never seen a population that when doing well is so worried. They're worried that they won't get their drug. They'll worry that they'll lose their drug. They'll worry that their drug will stop working. They're worried that that they won't be able to. That then the next drug won't work, or that they'll run out of next drugs to work. So that it is remarkable to me. I don't remember cancer patients worrying to the degree that our psoriasis patients do. And I think it's because they get this disease when they're young, they get it when they're 18, 19, 20, and they live with it for a whole lifetime. So that it's not just something that shows up when you're 60, or when you're older.
Thanks. So I was going to start to circle through you about, a lot of the policy around this area now is going to be talking about coverage as well as pricing and, patient access and those kinds of things. So just starting from if you could just think about it from a clinician's standpoint, quote unquote, do you need every TNF? Do you need every IL-17? Which could you, if a way to try to achieve higher value would be to limit your choice to one IL-17 or one TNF, what are some of the trade-offs that you think of in terms of the importance that you attach to being able to have access to, again, let's just start with the TNFs. Every TNF?
I'd say, yeah, I need them all. And I'd say that in psoriasis is different than psoriatic arthritis, or at least as I see it. Psoriatic arthritis, the efficacy for the 3 different TNFs in the treatment of psoriatic arthritis is pretty equivalent. But in psoriasis, they can be quite different. And then if you drill down to the individual patient, the efficacy can be quite different. So I've definitely had patients who will respond to one and not to the other, and then I flip them around, and then they respond to, and vice versa. So that to be very specific, there are people who will respond to etanercept and not adalimumab, and there are people who will respond to adalimumab and then not etanercept. So that I think that, and in fact, very commonly, patients sometimes who have IBD will, especially, but arthritis as well, will develop a psoriasiform, I call it psoriasis or psoriasiform dermatitis, and in fact, we are told we should switch amongst the TNF inhibitors very specifically, and that's okay to do. So that I think the idea that we need these drugs, that we could be limited to just one if that would make things more cost effective, would be, in my mind, very short-sighted, because I think we really do use these drugs differently for different individuals.
So you can comment on that, but also is the same true of the IL-17As in your opinion? Because I personally have heard more about the variation in response to the TNF inhibitors, but what's your experience with thinking the same thing about the importance of having the full spectrum of IL-17s?
Yeah, so I certainly echo what Abby said, and I think we said that earlier. My honest answer about the IL-17s, well, I should step back to say I'm not sure that we really have the full picture yet on persistence of, in IL-17 land. We've had a few. I can think of 1 or 2 people already where they were thrilled with their IL-17, absolutely thrilled, and its efficacy is now starting in 1 or 2 isolated cases starting to wane. And I'm excited to have another one. And I think for reasons that we don't yet have our heads around, having a variety of options does seem to matter. If for no other reason than that. That we do have to sometimes cycle through these things. It's a chronic disease, requires chronic therapy at present, and that's where we are.
So if I could underscore a point Abby made a moment ago about the fear patients have about losing access to therapies. We see patients who are stable and doing well really want to stay on the therapy they're on. And they have a lot of concerns about losing access for a variety of reasons to whatever that therapy is. And about half of the calls that the foundation gets into our patient navigation center have to do with access. And one of those transition periods is when they change jobs or change health insurance plans. And so that if they're doing well and if they're stable on a therapy and then they move to a new plan that has a different preferred agent as the first line therapy and they're told they have to change, that's very upsetting to them. And so there's a lot of questions that a patient has to go through about whether or not they make that change. And so I think I would just raise that again, that mental component of limited access.
So by the way, is there, I forget if we talked about this, are there studies of patients or even registries in which they've been on an IL-17 and it starts to not work and then they get put onto a different one? Do we have any indication of the success rates of second IL-17s in the published literature? We don't, right? Okay. Anecdotally, though, you're finding that some patients will respond to another IL-17, or you don't have enough experience yourself?
The experiences are very small ends. But yes, but we're a handful of patients we're talking about. So
okay. So I'll go one place and then I'll come back before we get to the payers. So we talked. You mentioned the concerns of patients about being able to stay on the same drug and changing jobs, and we'll come back to that. I'm kind of curious, we also didn't really talk that much about the price increases, and we've talked about how net rebates can affect that, but the patient out-of-pocket is usually linked to that list price. So what's the kind of the patient perception of wanting to stay on a drug as its price has been, as we saw, marching up pretty steadily over the past 3 years?
Yeah, so I think costs in general are a challenge to patients. Over the last few years, we've seen across the entire healthcare market premium prices rise, so patients are struggling with that. Certainly the out-of-pocket costs patients are experiencing are going up as well. There's significant cost shifting happening between going from co-payment models to co-insurance models, and so there's issues there. Of the access questions we get from patients, about 50% are related to cost. So we know that the out-of-pocket cost for patients does challenge them. I would just remind the group, too, to think about the fact that many patients that we're talking about here are also dealing with other treatment costs. So whether it's for other therapies related to their psoriasis or other comorbid health conditions, as well as costs within their family for other treatments. So, it's not just the one psoriasis therapy they're looking to afford. Certainly coupons and other patient assistance programs have been a critical part of our patient population being able to afford their therapies. That's not an option for patients in Medicare or Medicaid, and so we have a number of patients in those two populations that express that they are particularly challenged in being able to afford the biologics. But I think we do see preference for patients to stay on the therapies they're on, but they are certainly challenged.
So I kind of felt like this policy roundtable is going to be about 80 to 85% step therapy. One way or another, that kind of is, when we looked at the landscape of how these drugs are covered, and you all know this well, virtually all payers, certainly all the ones that we could find, both small regional ones, national ones, step therapy is the kind of foundation of the approach to coverage in this area. So I guess I started with you asking whether you needed access to every single one. From a clinical perspective, how does step therapy fit with the way that you think? As long as you still have access to them all, does starting with one, what are the pros and cons, the problems you faced? If step therapy is, we can talk about whether it should be, but from your perspective, can it be done in a clinically sensible way or not?
I'll start with that one. I think step therapy is probably the thing that is most detested by most physicians. I think it often requires that we start with a medication that really doesn't make sense for that patient. So, for example, in the psoriasis population, our patients tend to be very heavy. They tend to have a lot of inflammation in their liver as a consequence of being so overweight. And so methotrexate, which is very commonly the step therapy, is often what's recommended, which is a relative contraindication right then and there. Other step therapy edits, sometimes I can tell you some of the insurers I use have 3 and 4 step therapies, often with therapies that are, that are really fairly outdated. So I'm told that I should be using PUVA, which almost nobody is using for psoriasis at this point in 2016. So the hurdles that need to get jumped are often really seen by most providers and most patients as really just barriers in terms of getting to where they need to go. And they look at it and they just say, well, how many months do I have to essentially go through this until you're going to let me get to what I need to get on? And rather than, gee, this is a reasonable, cost-effective next step, so why don't we go there? So I think step therapies from most dermatologists' perspective are not particularly helpful. And ultimately, we all understand what the rules are, so we work them and basically get patients to, march through the drill to get where they need to go. But dermatologic drug development has been a monotherapy model, so that means, even if you think a patient, if you think a patient is truly going to have an adverse consequence as a result of being on methotrexate, it means it requires a lot of time on my part to fight with the insurers to explain why it's not indicated, which I do, but most practicing dermatologists don't have that time. And I can tell you that, I have, 1 to 2 FTEs at any given time whose sole job is to fight for drug access. And I think that's true of most people who have a very strong psoriasis practice. So, so that I think you're talking about a lot of waste to the provider, a lot of waste to the system, and ultimately, those patients do march that march and then go on to these other drugs. So to me, it seems a very inefficient way to allow for drug response.
All right. Joe, why don't you go ahead? Oh, and then we'll, go ahead.
No, I can echo that. I agree with everything Abby said. Step therapy has been a great pain to all of us. I think everyone clinical here is certainly. I think, and I don't want to keep sounding like the repetition of this, but it really is a unique disease. And, so being both a rheumatologist and a dermatologist, we treat lots of different diseases. There really is a lot of nuance in every case. I wish I could say, it was the 1 in 100 that was the unique case that we're talking about here, that everyone else fit the cookie cutter, but just give us some flexibility about the 1 in 100. But already we have the 30 in 100 that come in with a comorbid condition that we talked about, and even that one is so nuanced because and I have a fellow rheumatologist in the room. I can say this: we know from guidelines, we know from experience, for example, that even among that 30%, that's a high number. I think we'd agree. A third of these patients who come in, it doesn't just mean they have a peripheral arthritis that's going to respond to X. They may have axial disease. They may have enthesitis. They may have uveitis. And so if you give me etanercept as my first line drug, I'm in trouble. All right, in that one case, if they have really bad axial and whatever, and you give me ustekinumab, I understand we're talking about one domain of disease, but it's just such a complex group. I wish I could take that apart, but I keep coming back to it because we just need choices. And the step therapy approach, unfortunately, the step therapy is not sophisticated enough to allow the flexibility for all of these options. And I wish I could say, what, if you just gave me adalimumab, I'd get 90% of the way there and just, and then I can go from there. With some of my diseases, that might be true, actually. To be completely honest, with acne, maybe we could talk. But let's not go there. But this is it really is truly a unique disease with a unique set of complications that I think warrant a very thorough, thoughtful discussion as we're having here.
Chris.
Yeah, I hope I'm not beating a dead horse here by extending on what Abby said earlier about how frustrating it is to have to jump through hoops. Me as a patient, there's nothing more frustrating. I think having the disease itself is less frustrating than jumping through hoops to get the medicine that I need or, deserve. I might sound selfish there. But the goal is to get better. You have a disease, the goal is to take a medicine that helps the disease. So if I take one biologic and it doesn't work as well, why should I have to take something worse? Now, I'm no expert. I only know the numbers that my wife texts to me while she's at work. So I don't, I'm not a doctor or anything. I'm just a patient. Why should I have to take a medicine that's worse over something that's better? So it just seems like a waste of time, you know. I'm taking a medicine that has 70% effectiveness. Well, I can't take something that has 80% effectiveness until I try something that has 60% or worse effectiveness. Those are just numbers I'm shooting out there. But nothing frustrates me more as a patient than being told that I can't use something that will work better than what I was taking before I try something that's worse. I'm actually getting quite frustrated right now just talking about it. Seriously. I would rather have a flare-up than put up with that dance. So anyway,
Yeah, so going back, certainly this underscores Chris's challenge, but going back to what Abby said about the numbers of patients in our community that are not currently treating appropriate to the level of their disease. So about 55% of patients with moderate to severe psoriasis and 41% with psoriatic arthritis don't treat appropriate to the level of severity of their disease. And we know that when patients are pushed through a step therapy protocol, that quite often, if they can't get the therapy that their physician recommends, they will walk away from therapy. And so I think as a foundation, we're concerned about a process that ultimately potentially discourages patients from getting on a therapy and staying on that therapy. And so from the patient standpoint, as you heard from Chris, there's significant frustration in a process that's unclear. And we heard from Abby and Joe that even when the process is clear, that there are many physicians that don't have the bandwidth to fight the system. And so unless you're going to a physician like one of the two of them, in many cases you end up on a therapy that is not the ideal course of treatment for you.
Just want to make one comment.
Oh, please,
yeah.
please.
You know, one thing that we didn't touch on today is just how patients feel when they take these drugs. You know, it's amazing to me that a drug like methotrexate, I have to actually tell my patients, you probably want to take it on a Friday because you're going to feel pretty poorly for the couple of days after you take it, because this methotrexate is taken once a week, so that your weekend, you have your weekend to feel miserable, so that you're okay to go back to work on Monday. Versus the injectables, the biologics. I mean, people tolerate them usually really well. So, and that, how do you put a price on that?
So this was a topic that a number of patients touched on during the patient-focused drug development meeting on psoriasis at the FDA in March. And if you read the Voice of the Patient report, it describes it as methotrexate fog. And many of the patients express that they do that scheduling, but the impact on their life, then they're unable to really do much over the course of the weekend, and it really has a significant impact on their quality of life as a result.
All right, so now I get to do some difficult things, some difficult questions. I'm going to be provocative, pushy, devil's advocate in all different directions. I'll start with the payers, finally. So the evidence suggests that these drugs all have either intermediate or high value in the terms of the long-term benefits based essentially on their improvements of quality of life, which are quite substantial. Why do step therapy at all?
So from a Blue Cross perspective, there's a lot of reasons why we would do step therapy. Part of the reason is really we have a fiduciary responsibility to our clients and to our members to try to keep costs low while providing a variety of options and not creating a vast number of hurdles and barriers or burdens of administration. So we do take that into consideration. As the panel struggled with today, there's a lot of variability among these drugs. So really, what can we do for our 2 million members to create guidance and kind of drive to that lowest net cost, most clinically effective drug? And step therapy is one of the tools that we can do that with, along with benefit design and benefit formulary placement. So the use of step therapy is designed to really drive to that with having the ability to use those drugs that have been around for a long time. Docs know what they're doing with Enbrel, Humira, trade names. They know what they're doing with the DMARDs. Those three may not be always the first line agent or best for somebody, but when all push comes to shove, consider that in terms of cost and therapy. If that doesn't work, then we're suggesting try a second-line agent. So just as in a lot of medicine is done by step, we're just looking to use this as a practical, logical, cost-effective tool to kind of guide. It doesn't work for 100% of the people. We know that. That's why there's exception processes in place to allow people access to those drugs.
Paul?
Thanks, Tom. Don't have a whole lot to add to that, but I think Dr. Merola hit on a particularly crucial point. And as plan administrators, our default position is to use step therapy. And we have populations of millions of patients in our plan. So when we're evaluating a new-to-market drug, it is intuitive for us to try to establish what the incremental value of that drug is compared to historic therapy. So there are some circumstances where that step therapy is an unmitigated, easy policy decision to make. If you're going to start oral therapy for diabetes, you start with metformin, right? So piece of cake. So we tend to, because we have such large populations of patients, and we have challenges managing all of the volume of activity that comes through our plans, and as Tom said, we have a fiduciary responsibility, our inclination is to use the model that we drop the things into the model we use. So we may not be, there may be an argument that in the treatment of moderate to severe psoriasis, that our step therapy strategy should be something different. We often use the initial therapies as a marker for the step therapy, and actually is a marker for the severity of illness. Well, maybe that's a bad model to use in psoriasis. So we might assume that patients who can successfully be treated on methotrexate have mild disease. Everybody's happy and we move on. But that may not be the right thing to do in this circumstance. So among other reasons, happy to be here to learn a little bit more about the particulars of the treatment of this particular condition. So I think that is something that we probably have to take into consideration is, are our step therapy models sophisticated enough to deal with a particular disease? There's that. And then most pharmacy benefit managers approach the management of the pharmacy benefit from the drug. So when you have a drug that has multiple indications, like many of these biologics do, it adds another layer of complexity for the plan manager to design a benefit and deliver that benefit to our members, to our patients, in a way that acknowledges the particular needs of that individual patient. So we have work to do. I would not confess anything other than that.
Well, hopefully we're starting some of that work here today, or we'll talk about it. So, all right, so I'm going to push and probe back this direction now. So, was it 70 or 80% of patients treated with traditional therapy, PUVA and topicals, are satisfactorily treated? That was a number cited today of patients. So we get a fairly good response rate out of non-biologic therapy, 70 to 80%.
What I had quoted in my talk was that of all patients with chronic plaque psoriasis, so not moderate to severe,
of all patients, right,
are adequately treated with topical therapy. Yeah.
Okay. So why isn't PUVA used? You mentioned it not being used in 2016. It's, to my knowledge, isn't it still a relatively required part of step therapy for many insurance plans?
Was associated with an increased risk of non-melanoma skin cancers, especially squamous cell skin cancers. So for that reason, it's not often used in psoriasis any longer.
Okay.
It's in its place is other phototherapy. Maybe that's what you're, so narrowband UVB.
Oh, I get it. Other phototherapy.
Yeah,
right.
other phototherapy.
Okay.
Which, but we should add, increasingly, patients who typically come 2 to 3 times a week, who have to come for that therapy, are increasingly burdened with the cost of that, and often are paying a copay 2-3 times a week for their therapy, which you can imagine is highly burdensome financially.
Okay. So, but in your clinical practice, is it true that patients generally have to go through phototherapy, topicals, and either methotrexate and/or cyclosporin before they get their first TNF drug? Is that correct?
You can speak for Pennsylvania or for
Yeah.
Virginia.
I lived in Pennsylvania until a year ago, so I can speak about Virginia and Pennsylvania now, vice versa, I mean. So very commonly, certainly topical therapy, everybody has been on, will be on, and then most patients either will have needed methotrexate, sometimes methotrexate and UVB, sometimes methotrexate, acitretin, UVB, so that there are various combinations depending upon the insurer of what has to be first before a biologic is approached.
Okay. And then if we were to, let's jump over that hurdle to the biologics. I know that we've talked a lot, you've talked especially about the different unique clinical characteristics that might mean one drug as opposed to another. What % of those patients who getting through that first hurdle over methotrexate and all the other treatments could not be treated by either Humira or Enbrel? And you feel would really need the IL-17 or the IL-23 or something else? I'm pushing and probing about whether step therapy in which you start with a TNF before you go somewhere else makes clinical sense, because the vast majority of patients, it's a reasonable first drug to start with, either Enbrel or Humira.
So I'll gently shift the conversation. I should have gone to law school instead. But I would say, one thing that we're talking about more and more, and I think indirectly answers your question or offers a new approach, is a treat to target strategy. And I actually think it does answer the question, because what we should be thinking about, it's a tough question to answer, because when you say getting a patient to a destination, I'm having trouble defining what the destination is, right? So the destination is different for every patient, and so it's hard for me to say. How many patients could I get to 30% better with Humira? Very different question than how many patients can I get to 100% better, and where they want to be and everything, right? So I think it's not as simple, and so I think one of the goals of the NPF, among other things, has been to derive a sort of treat to target strategy and define the target, which we'll be hearing about in the near future. And I think actually utilizing that as an endpoint really would help us better answer that question, because then you can ask me how many patients on Humira reach this target, and then if not, what to move on to, or whatever it may be, if that makes sense.
Sure, please.
So do you anticipate the treat to target is going to be a patient sort of chosen target, or is it going to be?
Yeah, it's a great question. I can tell you my bias, but so the target that I think has been put forth in other arenas is very much an objective target. It's typically a body surface area or a PASI number or something along those lines. I think we'd very much like to see it include a patient-reported outcome for the reasons that you mentioned. I think it would be great for patients to also define what that endpoint is for them. There are a number of other models out there of minimal disease activity, remission, and/or target approaches that I think we're becoming a little bit better at. And in the value-based healthcare era, I think many of us would be good too, because we could be held to those numbers in terms of our.
But in terms of the PASI that's chosen, would it be chosen by it says I will be 80% better is victory for me, for the individual patient, and somebody else it might be 75, somebody else it might be 95.
I think that's right to some degree. I think it would be maybe less. Maybe it's based on a combination of body surface area and DLQI or something like that. But yes, I think that the patient voice infused in there really would be an ideal scenario.
So I want to return again. Well, go ahead. You can say what you want. But my general question is, and then I'll move to the very difficult topic of harm. What harm are we doing by trying a less effective drug? Seeing if it works, because we know that, again, for etanercept, which came out, if you will, at the lower end of the effectiveness scale, still, 44% of people, 50% will have a PASI 75. So I'll head there, but back again, if you were going to construct a step therapy in which patients got access to any TNF first, does even that not make clinical sense? Because there are enough patients who would need, quote unquote, an IL-17 or an IL-23 first before trying one of the TNFs.
You know, the problem that I'm having with your construct is that that every patient comes in with a different concern. So, you know, and I appreciate why you'd like to say, well, we'll explain that caveat and be sure to stress it, but it so often comes up in clinical practice. So, you know, when I think about your answer, certainly if I had all three of the TNF inhibitors, that would give me some flexibility. That would be an improvement over what I currently have. But it certainly would not address the needs fairly commonly. So, for example, when people have concurrent IBD, then I need to be able to shift my plans. When people, when patients have issues with doing self-administered injections, I need to be able to shift my plans. So, I think that's where we struggle, because the IL-17s really, have a unique profile that can be very helpful.
Okay. Yes.
Thank you. I have a comment about the general concept of step therapy and the use of algorithms for decision-making in medical therapy. So typically, we go through a process to determine what the steps we take to treat a particular condition. So it seems logical to me that there would be a step therapy, for lack of a better term, but I know that's pejorative, so let's call it a treatment algorithm or a clinical pathway that one would use to approach the condition of psoriasis, plaque psoriasis or otherwise. So you use those kind of decision-making tools either because you have consensus guidelines from your professional associations or in your practice and your experience and so forth. So it is, and where I'm going with this is that when the Medicaid program makes a coverage determination about how to pay for a particular drug, we're held to a standard of medical necessity that's defined in the law. And we have to make sure that the medication, in this case, that we're paying for meets a three-pronged test. One of those tests is that it's the least costly alternative likely to achieve the intended benefit. So that kind of gets at the question around each prescription being a therapeutic experiment that may have benefit for that particular patient, and from the distance of the insurer, we say go at it, try the least costly thing that may work, kind of to Dr. Pearson's question. Another thing that we deal with is, in that medical necessity determination, is whether or not the intended therapy is at an appropriate standard of care. And this was intended in the Medicaid program to protect Medicaid beneficiaries from receiving substandard care. But when I look across the domain of how other insurers, how the medical community approaches the treatment of plaque psoriasis, my plan does what appears to be the standard of care. So, and some of that goes to the consensus guidelines that are established by professional organizations. So if I look at the American College of Rheumatology, and I see that PUVA is still listed as a first-line therapy, or that methotrexate is listed as a first-line therapy for moderate to severe plaque psoriasis, I think that there's a problem with that guidance. So to me, there's an obligation on the part of the treating community to change that, because we are heavily dependent on that, at least in my plan as a payer, to look at what the appropriate standard of care is. And if we can find a consensus guideline, we go right to it. It gets integrated with deliberation directly into our treatment plan or into our coverage decisions. So, done.
So with regard to guidelines, I think this is something that we've heard from payers. The National Psoriasis Foundation convened a payer roundtable this January where Abby, Joe, and I spent the day with a group of payers trying to talk with them about what challenges they had in designing coverage for our community. We certainly heard that up-to-date treatment guidelines are critical. and a valuable tool that they look at. So we're actually working with the AAD to update the very out-of-date guidelines for psoriasis, and have just begun an effort with the ICER to develop guidelines for psoriatic arthritis, since those don't exist. So those will be out in for psoriatic arthritis 2017 at this time, and for psoriasis spring of 2018. And so it's something that I think we recognize is important. I would say, though, that the pathway through step therapy and the clarity of that pathway, both for physicians and patients, is really critical. And we've seen a number of physicians just express that they don't have the ability to navigate that across all the plans that their patients are on. Understanding what those exception processes look like, and then having the staff to do the work to get through them, is a challenge, which is why, from a policy standpoint, our organization's been involved in legislation to address step therapy exceptions. And so you have now 15 states that have passed legislation to clarify what that process looks like, and make it easier for patients and physicians to understand how to ultimately get the patient to the appropriate treatment.
In regards to that, one of the things that we hear a lot from patients is that if they were trying to pick an insurer, can they even find out what the step therapies are for their condition when they're trying to pick between, I'll just say, Aetna and Anthem or whatever it might be? Has there been any policy development that you're aware of that we could emphasize in terms of helping it become more transparent to patients when they're selecting insurers?
So certainly, formulary availability is hard. I mean, when patients are looking at purchasing healthcare, there's obviously a number of things that they should be looking for. We spend a lot of time counseling patients not just to look at premium costs, and to look beyond that at things like what the cost share is. For patients that are on a therapy today, many of them want to know, is that therapy going to be available in the plan that they choose? So having the national formulary for that particular health insurer available is important. But whether or not the plan that they may or may not be looking at uses the national formulary is a question. I mean, there's a lot of variation there in terms of what formulary the plan does adopt. And then certainly, as you've heard, with patients going off therapies and trying something new, who knows if a year, 9 months into the year-long plan they're on, if they're going to need access to something else, and then whether or not that item will be covered. So certainly patients are looking for more information. But that information is typically not written to a patient audience if they can find it, and it is challenging, even for those that are trying to guide patients.
So sure, Tom.
Just a comment from Blue Cross. So our medical policies, our formulas are all public knowledge. It's all based on our website, et cetera. We have a pharmacy and therapeutics committee comprised of physicians and pharmacists actively practicing in Massachusetts to help us make some of these decisions. We've got a rheumatologist on the P&T committee. We've got a dermatologist on it, an oncologist. So again, to help us get through some of this, to make sure that we're really not creating an excessive burden. But in terms of step therapy, I just want to point out too that it's another way, another term for it is a smart prior auth, because there's coding that can be done at the point of sale at the pharmacy that allows the pharmacist at the time of adjudication to look back at a patient's claim history. And if there's history of a step 1 drug or a drug that was used in the previous 120 or 180 days, that claim will process automatically, so the payer so the physician or the patient doesn't have to go through that hassle of prior authorization and filling out a form. So there's tools that can be used to make it easier and smarter, and we try to take advantage of those anytime possible.
I mean, unfortunately, it's, when they're changing plans, and they come in, as you pointed out, changing jobs, changing insurers, that kind of easy information transfer doesn't happen.
It doesn't, but there's also, with us, it's been, for the past 8-9 years, we've had a plan in place where any member with eligibility less than 90 days old, either coming in from a new account or as a new employee, will bypass step therapy. So if they've been on that drug, they don't hit that edit. we've built that again as a smart rule as part of Smart PA to allow them to continue on therapy without being interrupted. So that's becoming more and more common.
It is.
But yeah, but it is,
Well, that's
it's
something we may
a
want to
good
note
tool
in our
to
report.
take advantage of that hopefully is being more widely used.
Okay. So let me push back this direction again for a second. If you look at articles about the ethics of step therapy or some of the considerations, one really critical issue is whether failure on the first drug leads to irreparable harm that you can't catch up on by switching to the second drug or third drug. So, devil's advocate, people trying to manage a very big part of the drug spend, looking for as much value as possible, say that the less expensive TNF drug has a 50 to 60% success rate. The others have a 70, 80% success rate. We try them, it's like a treat to target in a way. We try them on the less expensive one first. We give them 6 months. If they're not to target, then they can move to the more expensive one. The harm done over that 6 months versus not doing step therapy at all. Do you think it's unreasonable to consider, talk about the harm done and whether it is, again, in the big picture of things, I'm trying to push from different directions. Is it unreasonable to consider trying a less effective drug, given that you can go to the more effective drug if it doesn't work?
Well, I'm going to answer you this way. You know, I've noticed in the last decade, pharmaceutical company trials have migrated from being primarily US-based to being primarily global. Now, some of that reflects the fact that we're a global world and they're global markets, so I accept that. But that's not all of what motivates that. A lot of what motivates that is the need to get naive patients because they give a better response. And so I think that I think the companies obviously understand that this is the case, that when you introduce a drug to somebody who's already been on a drug before, the success rate is going to be lower, and they are mitigating that. So I think that's certainly an important.
Is there truly evidence that if you treat with secukinumab after having treated with adalimumab first, you randomize patients to start secukinumab versus adalimumab and then followed by secukinumab? I would doubt that we have evidence to compare the response rates for the secukinumab arms.
I can sneak up on you from behind.
Go ahead. Sneak up on me from behind.
Yeah, I think we do have data. We don't have it for all 8 of these medications, but anytime we've looked at this, and this is in the full report, the subgroup of patients who have tried prior biologics, because none of them have been on apremilast before, you do see lower average response rates. What we don't see is effect modification with the new. So there's not a differential response apparently. So it's just a lower overall response, but not a differential response of say one medicine or the other given prior therapy. We've seen no evidence of that.
Yeah.
Makes sense.
Yeah. No, I think that's great. I'll tack on 2 examples. I think 2 different mechanisms maybe. So one of them is a scientific one. I don't have the exact, but to come to the evidence point, I've seen many times, and I find it really drives home this point. There was one of the ustekinumab trials looked at capture of a response essentially after 1 TNF failure, 2 TNF failure, 3 TNF failure, and there's a nice sequential response, right, or inverse response, essentially.
Again, so patients who fail 2 versus who fail 1 are going to be.
So if they failed 1,
they're going to be more likely to fail a third, no matter what it is. Just like a cancer patient, once you've failed twice, it tends to mean that you have a more severe form of the illness that you've had all along. So the question is how you tease out.
I understand.
The effect.
So there's going to be a mixed group. I mean, so there's probably a population of people who have very recalcitrant disease, which is what you're getting at, and then there are people who are that there is a recalcitrance either to the mechanism or you've chosen the wrong mechanism. I can say now because I think it's already public knowledge. But we've seen, for example, there's a recent paper that looked at failure of, for example, psoriatic arthritis patients to a number of biologics who then got a JAK inhibitor and suddenly had a response again, okay, or had an impressive response. So there is a scientific basis for this. And the other piece that's not the scientific piece I wanted to come to is if you give a patient something, I'm going to use Chris as an example. You know, if he comes to me and he's got bad skin disease and I give him a puny therapy, there is an unfortunate chance that he'll say, okay, you really don't have anything for my disease, and not come back. There's the failure to capture a patient based on their interpretation of our inability to treat their disease. And that's an unfortunate loss, and that does happen sometimes. So if we're going for the low ball here, they have to understand, hey, you know, coming into this, there's a good chance, or there's a really good chance it's not going to work. So hang on, hold on with me. Let's do this for 3 months. You'll be miserable, but after that, we'll try something else. You know, you know.
Right. But would you think it'd be interesting or not to do a study in which you randomize patients to TNF followed by IL-17 for those who don't respond, or you get IL-17 and a TNF if you don't respond?
Do you want to?
Would that study make any clinical sense to you?
I mean, again, Steve, but the
kind of do that.
And I would add, though, the differential sort of lower response rates among people who have been previously treated doesn't mean it's sort of hopeless for the, you know, what I have in my head of sort of the graphs, it's about like a 10% lower response rate. So it's not, you know, it's not dropping down to from a PASI 75 rate of 60 to 20. You know, it's going down 10% or so. And Dave and I, through this whole process, have been shaking our heads about exactly what you're asking. Like, there's no evidence out there about what should we do next?
Yeah.
Like that
Well,
evidence is not.
To be fair, our colleagues in the industry have designed a good number of either adaptive trial designs that allow for, you know, non-responders to cross into active drug and see response. I mean, I think we do have some of those answers, you know, indirectly, not exactly the real-world population you're looking for, but.
And I think from the patient standpoint, I was with a patient this week who's on her 6th biologic. It's an IL-17, and she's clear, almost clear. And that was after years. She's in her 40s. She was diagnosed as a teenager, so years of trying and failing after some point in time. I think that the mental impact of that cycle cannot be underscored. So, you know, from our survey data, we know that 2/3 of patients feel frustrated, angry, and hopeless are the 3 words. And then again, it's that 50% of patients report a negative impact on quality of life. So when you take that cycle and then couple it with those conversations and the frustration of going through the whole rigmarole over again, you have a lot of patients that walk away, and there's our number of patients that go on and undertreated.
All right, a couple more questions for the payers, and then we'll actually probably start to have some final comments. It's amazing how quickly this can go. So I was reading the other day, and this has been announced for at least a month now. So some payers, Express Scripts has announced a program, you know, looking for different ways to manage value. They've come up with an approach where they're trying 2 things at the same time. One is they're doing indication-specific coverage for psoriasis versus IBD versus RA, because their view has been that too often one drug will get kind of picked based on one dominant kind of indication, and it will kind of swamp the ability of niche drugs, which might even be better, to kind of compete in that class. So their view is that they have the bandwidth, whatever the business bandwidth, to be able to compete within indication, so that their preferred drug for psoriasis might be different than their preferred drug for psoriatic arthritis, might be different than their drug. So that's one thing they're doing. The other is that they are working with, I'm not sure how closely it is actually in collaboration with manufacturers, but certainly with their clients, they're saying, I believe it has to be within collaboration with manufacturers, if patients discontinue their drug within the first 3 months, the rebate goes, they basically refund to the plan sponsor the entire cost of that prescription. So that they're basically saying, if for whatever reason, that's probably a marker that it didn't work, or who knows what else is going on, but if that prescription isn't renewed, then the full cost of 3 to 6 months prescription gets refunded back. And they're also doing this indication-specific approach to coverage. Comment on those or other innovative ways that you think benefit designs and coverage could get a handle on value, either in lieu of step therapy or as an adjunct to step therapy. Are there other ways that you can manage value similar to what Express Scripts are doing. What kinds of potential do you see there?
I'll pipe up first because we actually use Express Scripts as our PBM, and we're rolling that program out on 1/1. So we are changing formulary with respect to that. They have not been able to treat drugs that have FDA-approved indications for multiple conditions in the past. We've been asking for that. We finally have it now with this category, so we're trying that out to see how it works. But with respect to the second piece of the program you mentioned, there's another catch to it, that you have to use the Express Scripts specialty pharmacy as the exclusive vendor. In Mass, we have any willing provider, so we can't really do that. We also have a network of specialty pharmacies that we kind of manage those drugs across to, again, provide greater access to. But it is another creative way that we're looking at for some of our self-funded clients to take advantage of that exclusive relationship to push that better bargain.
So if you're doing this indication-specific preferred drug approach, is that going to address some of the concerns of the clinicians about the step therapy?
Yeah, it's going to
change their ability
to change the step therapy to open it up a bit more, to make it less restrictive based on indication, and give more choices based on indication or condition.
Okay. I wasn't 100% sure that would have been your answer. I thought it might make it even tighter within
No,
indication.
it actually, in our case, it
will open it up.
We were pretty loose in the beginning with it, but it actually gave us the opportunity to loosen up a little bit more, which is great.
Okay. Paul, did you have something?
We're not there yet. As I may have alluded to in an earlier comment, we treat the drugs as a group of drugs, and we would like to be more sophisticated about an indication-based approach. There are some other, so we do have an opportunity to get better at that. There's also, to me, value-based contracting with the pharmaceutical industry is still experimental. And that one of the perhaps consequences to be thinking about is how does the company embed the expense of a value-based contract into the price of the drug. So it's not for nothing. No company gives away its product in an act of disinterested generosity, I'm sure of it. So there will be a cost for that. And we've seen over the years in the pharmaceutical industry, because of the Medicaid program is a large contributor to this particular problem, that when the public payer gets involved with influencing the way a manufacturer's products are used, that the prices typically go up. If we're going to get a higher rebate on a product in the Medicaid program, that usually shows up on the front end price of the drug sooner or later. So it's the type of issue that I know, that's part of what you exist for, is to help us figure that out. So, but when we have not entered into a value-based contracting, and I'll just say a proviso here that there is some concern about whether or not value-based contracting in the commercial world will affect the Medicaid best price. So the way those deals have to be structured, there has to be an understanding on the part of the parties, particularly on the pharmaceutical industry side, that arrangement doesn't set a new Medicaid best price. So if the drug is given away at zero cost for failures, does that set a new Medicaid best price at zero for those drugs? That creates a real problem for the pharmaceutical industry.
I'm pretty sure it doesn't. That's why this approach is being favored.
Exactly.
No, it's better than differential rebates. If it's somehow it's like a refund, somehow it's considered different. All right, I have one more inside fastball for you guys. Let's assume for the sake of argument that the state of the world doesn't change tremendously overnight, and we wake up tomorrow and there's step therapy for most coverage. What about the patient who's the good soldier and does the drug A that they're supposed to first, and they don't get adequate response from that treatment, so they go to drug B, but suddenly drug B's copay is much, much higher. They've done what they're supposed to do. They've tried the drug A, they're at drug B. Is there an argument to be made that they shouldn't have to pay more out of pocket for drug B than they did for drug A?
It's an easy question for Medicaid to answer.
It's easy for you.
But I like your thinking. It seems inappropriate to penalize the patient. So you would think.
Easy for you to say. Right?
Exactly, it is easy for me to say. I say that because Medicaid patients have nominal copays. So they're paying the same $3.65 copay for a $1,000 a month drug as they do for a $100 a month drug. So it's, in one way, that's a challenge to engage the patient in the consumer part of the decision-making process, but we don't have that type of ability in the Medicaid program. Tom, on the other hand.
Tom?
So that's my problem. So for the vast majority of our book of business, it's a closed tier 3 formulary with copay. So it's either a $35 copay for a tier 2 drug or a $50 copay for a tier 3 drug. So the incremental difference isn't that large, but there are some of our self-funded plans that are looking at coinsurance, and it's a very difficult conversation to have with them as an account, trying to give the best value and benefit to a employee with trying to rein in some of the costs. So, but pharma's been good about really their coupon program. So that's another avenue that is open in those situations, unfortunately, for them to take advantage of.
So, out-of-pocket cost shares are really hard for patients, and we know that the higher the cost share goes, particularly once it goes over $100, that you have adherence issues. And with these therapies, in many cases where there is coinsurance, we're talking coinsurance of 20, 25, 30, 35, 40% of expensive therapies. So we're looking at patients hitting the out-of-pocket maximum potentially in the first month or 2 months of the plan year. There are, as I mentioned, some patient assistance programs. Those often run out in January. And so you have patients who don't have the ability to afford their medication. The programs that are in place to help them don't have funds. We're seeing some plans limit the use of coupons. So if you're not, even if they allow coupons for one of the biologics we've talked about today, they may not allow the use of coupons for other ones as a way to encourage you toward the therapies they would prefer. We're seeing more and more plans limit the use of grandfathering, which historically, if you were stable and doing well, they would allow grandfathering. More and more ESIs, one that's talked about eliminating grandfathering. And so, that's a challenge for patients, and again, adds to the worry and concern that they have with staying on therapy.
All right.
And that's not to talk about the Medicare population with Part B versus Part D, with infliximab coming under a Part B benefit.
So
very different.
The NPF has talked to folks like those at the end of this panel, and they would tell you that for the aging psoriasis population, moving into Medicare and going off of the biologics we've talked about today are very big concerns of theirs.
All right. So thank you. Given the time, this is a very rich discussion, and I appreciate your willingness to let me push you in different directions to kind of see what we've learned. I'd like to offer you the opportunity in a final comment to make if you could have one stakeholder do one thing to improve the quality and value of care provided to patients with plaque psoriasis, what would it be? One thing, it could be someone that you're going to ask your own kind of camp to do, or you're going to ask somebody else to do. One thing that they could change that would improve the care for patients, both on the quality side and the value side. You can start.
Oh, no, I think you'll...
One thing.
I'll just agree with you.
Who would do it, and what would it be?
I think I would really ask insurers to work to eliminate step therapy, because the burdens are so huge and often so needless, and create such frustration for patients. And often, as it is, we struggle with over half patients being undertreated or not treated. And I think one of the large reasons has been the fact that there's such a rigmarole to getting drugs. So that would be my ask.
Oh, she stole my answer. I think I really would have to echo that, to be completely honest. I mean, I'd like to think that, we could bring back the discussion of which is the right drug back to the patient-doctor discussion. I think that really is, I hope that our goals are aligned with our patients, and I know I'm going to get tomatoes thrown at me from everyone who's trying to contain costs here. But you know, we're ultimately patient advocates, and boy, it's a great feeling when you fix someone and you get them to where they want to be. And so I just I'm gonna agree with Abby. I think it's really. We certainly don't try, I can tell you for myself, I certainly don't try to abuse the system in any way, shape, or form, and I lay out my options for patients very thoroughly, and I hope I'm making an informed clinical decision based on all the evidence and stuff we talked about today. So.
All right, thanks. Chris?
Let's see, if I can improve things in one way. It's hard to choose, there's so many. I think it would just be, you know, I don't expect to, you know, well, obviously, to be able to afford my medicine without having to sit on the phone for an hour, you know, negotiating how I can make that happen. So no more step therapy, like she said. But also, you know, just, I would really like to, I don't expect to be cured anytime soon, but I would like to feel secure in the thought that someday I will be. And I think being able to get my medicine would kind of help me on that journey. So if I can improve things in just one way, I'd have to say easier for me to afford what I need to get better. So.
Yeah, I would certainly second the impact of the patient cost issue. And I would say that the point Abby and Joe made in a slightly different way, which is preserving the provider-patient decision-making as the place that treatment decisions occur between the patient and the provider.
Thanks. Tom, how would you make the world a better place?
I would like to see there be more transparency in pricing of pharmaceuticals, as well as just so that it enables groups like this to really take advantage of, you know, having a better cost and see a sense of what those products truly cost, so we can make access increased and better available to patients.
Paul?
Well, I could say drugs for free, but I think from my perspective, and I mentioned this earlier, in managing my plan, I would love to see the consensus guidelines from the professional practice organizations be crisp and up to date, so that in trying to manage a large population of patients, we can zero in on the specific needs of the patients with plaque psoriasis, and not throw that bucket of patients in with the whole universe of patients, because the professional societies and the advocacy groups have created a standard of care that will help direct the way we manage the benefit.
All right. I just want to say, I think it's really wonderful. It's not something we get to hear all the time, and there's folks who are part of the population who make those guidelines or on those panels. It's really great to hear. It's really important to hear that, because that's something we can bring back and work on ourselves, because I think there's not as much of a two-way street discussion, and that's unfortunate. I think sometimes I think we're trying to do you a benefit by keeping the less expensive thing in the mix and not really thinking about and so it's really actually quite important to hear that and think and take it back. So anyhow,
just by way of reference, the National Coordinating Council on Chemotherapy, what's NCCN? I don't have that right. I apologize. Thank you. Their guidelines are updated almost overnight. Drug comes to market on Monday. By Wednesday, the guidelines are updated. That is enormously useful. Just saying. When we look at a guideline that is 4, 6, or 8 years old, it's like, what's going on here? What do? We make our best efforts.
All right. Thank you. We're going to thank them when we get to the very end, and in a very abbreviated, I'm sorry, but I know some people do need to leave at 4 o'clock. So I'd like to give the CEPAC a chance to go around and have a final comment. It can be something that they found most persuasive and want us to make sure that we capture it in the final report, a personal reflection, anything you'd like. We'll go quickly around. If you can try to keep your comments to 30 seconds or less. I'm just trying to count the people and see if we have enough time. So Julia, we'll start at your end and go around.
It was very helpful today to hear and appreciate the complications of psoriasis and how difficult it is. The step therapy issue seems to need to be focused on.
Thank you, Steve.
Just wanted to recognize the manufacturers for bringing a dramatic breakthrough to this therapeutic area. We shouldn't lose sight of that at a value at which we pay for other interventions in healthcare. And it's a shame patients are getting caught in the crossfire. So thanks to Mr. Pettit for coming out and sharing that perspective with us as well.
I wanted to thank ICER for a number of reasons, one of which is I know how hard these reports are to generate. So as usual, a huge amount of rigor and detail, and we really appreciate it and benefit from it. And I also wanted to thank the ICER staff for really bringing a remarkable number of interested stakeholders and experts together in this room. I will say in particular, one thing I will take away from this is how challenging this disease is to live with. The heterogeneity of different presentations between different types of patients and the fear that it engenders. I mean, hearing about people's kids and stuff like that, that really is something I'm not going to forget. And to be perfectly blunt with you, I'll say that I'm probably not always as knowledgeable about it as I should be. It's a skin condition. It's, I think that, I'm a cardiologist, but to hear that the quality of life creates a utility weight that's equivalent to a, immediately life-threatening process, I think is very substantial. And I got that from lots of different people today, and I appreciate that perspective.
Thank you. Keith?
I think the whole step therapy prior auth thing rings true for me. As an internist, I understand the necessity for it, and I think in some disease entities, it's a good thing. With moderate to severe plaque psoriasis, you're just kicking the can down the road, and you're eventually going to end up on the right drug that you wanted to put them on right out of the gate. So I would certainly hope the insurers will hear that.
Thank you.
Well, this particular session was remarkable, I think, for the number of drugs involved, which made it a lot harder for the staff to prepare. And I speak for myself, and it made it harder for me to prepare. But it also brought to my mind the particular problems of a condition that is lifelong, that if you get a bad cancer, it's not going to last very long, and so then that one's over. But the people who have conditions like this just have to live with it all the time, and that has a tremendous effect.
Thank you. Chris?
I'll echo those sentiments of Dr. Snow. Even the health economics in this condition are idiopathic. We don't know where all the costs come from, episodic, heterogeneous has been mentioned, obviously, and unknown in the counterfactual scenario. If patients were to go down a different alternative path, where would they end up in terms of their needs being met? So I would say that bringing value to this condition is not yet fully functional, but this is a great path in the right direction. So thank you.
Thanks. Kim?
I would echo everybody's sentiments in putting together a fabulous report. This was very complex, and you did a great job. As far as takeaways, I want to thank the experts for shedding some light coming from the payer perspective. I do agree with Dr. Stahl that I think step therapy is a necessary evil, but I think what you did for me is at least shed some light on the different severities, and making sure that we account for that is important. And I would ask that prescribers try to understand that we're not there to be confrontational, but we're trying to budget as well as balance access, so it's hard.
Right, on this particular one, I was impressed with the range of patient heterogeneity and how that interacts with the modality of treatment, oral or frequency of shots and so forth. And that's clearly very important, I think extremely difficult to bring in quantitatively into our analysis. So I know it'll be addressed descriptively in the report, but I think it's very, very important, so I want to just emphasize that.
Claudia?
I want to thank ICER for paying such close attention to the patient experience and bringing that in in the report early on with patient advocates and here today. And just following up on your challenge of what all of us stakeholders can do, I think one thing that costs nothing, but I heard from some of the people who spoke about psoriasis today, is that we can all be kind, compassionate, and speak up to dispel myths around the social stigma. So that's something I hope we can all do, regardless of what else happens clinically.
I want to focus on something I struggled with, which was the cost-effectiveness ratios and why we were flipping between A and B in a couple of the decisions, and then to relate it to a comment that was made during the public comment period. We waited 6 months for this, and that was harmful to people. I think what we discovered in this, the arbitrary thresholds of 150,000 and 100,000 were really not very useful. The range of all of the drugs fit within 40,000. So we could have thrown out those thresholds and basically said, these are all essentially equivalent in cost effectiveness. And I think that's the strongest case for not having a stepped therapy. I don't think we could have said this 6 months ago and just gone to that without going through the rigor of doing all of this important work. So to the public member who sort of questioned the value of ICER, to put it bluntly, I think we justified the value of ICER by going through with this and maybe coming up with this conclusion that just in the case of psoriasis, maybe other conditions, we don't need step therapy.
Okay, thank you. Stephanie.
And I just wanted to say thank you to ICER for putting this report together and getting everyone into this room. Thank you so much to the panel members. That was very, very helpful. For me, as I listen to this and I see us move from near cure in a lot of people, I think about the next step. And so I think about your comment earlier about people who are treated and still have severe anxiety. And so I would like to see more studies in that population, specifically looking at anxiety, looking at depression, because we know that the link between psychological and physical well-being is so strong. And so perhaps if we can get those things under control, patients will respond even better to earlier line therapies.
Okay, thanks.
Yeah, I was struck by some of the public comments about the controversial nature of some of what we're doing, but I think that there's a little bit of a misunderstanding about CEPAC and ICES, because what we've done today, I think, demonstrates some of the value of bringing this level of rigor and deliberation, and then ultimately saying that some very expensive drugs are very valuable to patients and present a value to the healthcare system. And I'm not sure that comports with the perception, but I think that's what we did.
Greg.
Thanks very much to the panel and to ICER. It's been, for me, a very illuminating day, so thank you for that. I think that given the heterogeneity of response to these agents, that value-based pricing, to me, makes a lot of sense, so that patients can find the right drug for them with less financial burden. And also, in fairness to patients, I hope that our manufacturers will introduce a little more realism into the direct-to-consumer advertising.
Well, I want to thank the panel as well. This has been most enlightening for me, being a layperson. But what I have found today is just the complexity of this disease. I never was aware of all of, it's just overwhelming. However, I'm hopeful that we can begin to put the pieces of this puzzle together to come to some kind of resolution, and I'm hopeful about that. I want to say something, Chris. What struck me is you made a statement and you said, I don't think I'll be cured. And that really resonated with me, and I'm just hoping that that may change very soon. And so I just say be encouraged. Thank you.
Hey, Teresa.
I just want to thank everyone as well, the panel, ICER, members, public. This is always a very enlightening discussion. I think our next topic is rheumatoid arthritis, and we'll be dealing with some of the similar drugs in a different application, but we'll be clearly dealing with a lot of the same issues, so it'll be very interesting. And thank you.
So it comes to me the honor of thanking our policy roundtable members. They all came here today, some of them from far away. These meetings, as you can tell, are a really important blend of evidence review and input from stakeholders and a real wrestling with the policy. And I just want to thank you for the spirit with which you entered into that today. So thank you from all of us. Thank you. As far as the next steps, just briefly, I thought we had a next steps, but the next steps will be to capture the results of the voting. Some of the richness of the discussion around it will be put into the final report, and we will create a version of our report that normal people will actually be able to read. It'll be, we call it a report at a glance. It should be available approximately 2 weeks from today, so you can what's that? December 2nd. That's about 2 weeks. 2 weeks, about 2 weeks from today. So we will certainly distribute it to the participants, but it's always available on the ICER website for others. Thank you to those of you who came and participated in the meeting, the public comments, and generally. And thank you again very much to the members of CEPAC who also come from wherever they live in New England 3 times a year, wrestle with the evidence, wrestle with the deeper issues, and always also infuse this proceeding with the spirit for which it was intended, which was to bring these kinds of conversations to the public in a way that we can all learn from. So thank you, CEPAC. And with that, we'll adjourn. Safe travels, everybody. I hope you travel well. So, now it's